Okay, good morning. Start off with osteoporosis and bone health, an exciting topic to kick off the morning. So it could get very detailed, but I've got 20 minutes here, so we're going to try to roll through this. Objectives, we're going to review the definition of osteoporosis and fragility fracture. We're going to review the burden of osteoporosis. What is DEXA and its use? Understanding T-scores and Z-scores, those charts you get, when you order a DEXA scan in the office, you're like, what is this? Thankfully, we've got Dr. Brandan that helps to interpret it. That's very big. Understanding the use of FRAX, and discuss other modalities to discuss or to diagnose osteoporosis. So, fragility fracture. Definition, any fall from a standing height that results in a fracture. Most fragility fractures occur in the spine, the wrist, and the hip. What is osteoporosis? World Health Organization. I tend to like that definition the best. It's a silent disease. It's characterized by low bone mass, bone density, and very important, microarchitectural changes that leads to deterioration of bone tissue, and it leads to fragility and elevated risk of fracture. So what's the burden? Worldwide, 200 million women have fractures or have osteoporosis. There's nearly 9 million fractures annually. Globally, 1 in 3 women and 1 in 5 men over the age of 50 will experience a fracture due to osteoporosis. In the United States alone, 54 million Americans have osteoporosis and low bone mass. Studies suggest that 1 in 2 women and up to 1 in 4 men age 50 and older will break a bone due to osteoporosis. This third point here really relates to us quite a bit. 20% mortality rate for hip fractures in the first year. That's significant. 2 million broken bones yearly with an estimated cost of $19 billion to the healthcare system. By 2025, experts predict there will be 3 million fractures due to osteoporosis with an estimated economic cost of $25.3 billion. Here's something interesting. Postmenopausal women, this was in a study with a median follow-up of about 12 years, they have doubled the risk of experiencing a non-wrist fracture, experiencing a non-wrist fracture with women who did not experience a wrist fracture. This was women who had had a wrist fracture and they had another fracture. And this includes fractures of hip, non-wrist upper extremity, and spine, humerus, and lower extremity. That's significant. After a first fracture, Women's Health Initiative, the risk of subsequent clinical fracture is elevated 5-fold in the ensuing year compared to less than 2-fold over a 15-year period. So again, that if you fracture, it's a fragility fracture, you're at really elevated risk. Here's another important point. Decreased treatment rates for osteoporosis between 2002 and 2011. In 2002, 40% of patients were getting treated after hip fractures. But by 2011, 9 years later, it was down to 21%. And along with that, in an observational cohort of U.S. insurance claims, 65% of patients with hip fracture were not treated within 12 months of being discharged from the hospital. A single vertebral compression fracture, which I'm sure everybody here knows somebody that's had a vertebral compression fracture or has treated it, increases the risk of subsequent vertebral compression fractures up to 5-fold, and the risk of hip and other fractures 2 to 4-fold. And again, most of compression fractures that we see in the spine are asymptomatic. There's an example of a compression fracture right there. Okay, so how do we diagnose osteoporosis? Of course, the wonderful DEXA scan. As an example of a DEXA scan, patient lies flat on a table. In this example, the patient is getting their lumbar spine checked. They put their legs up on a pillow, flexed about 90 degrees. DEXA scans, dual emission X-ray absorptiometry. It's low-dose X-rays, so there's radiation involved, at 2 different energies to distinguish between bone and soft tissue. It measures the bone mineral density, so it's that number you see on the DEXA scores that says grams per centimeter squared. And it is the gold standard to diagnose osteoporosis. Although, as we will talk, there are some other methods you can do to diagnose osteoporosis besides DEXA scan's important, and you'll use the bone mineral density and T-scores, but we'll talk about that in a little bit. Of course, you measure the bone mineral density of the lumbar spine and both hips. If for some reason you cannot measure the bone mineral density at the hips or the spine, you can use the non-dominant forearm, called the 33% radius. Typically, that's because somebody's had a total hip fracture, or if somebody's had spinal fusion, lumbar spine, you'd go and use the forearm. Advantages of DEXA. It's painless and non-invasive. You do not need to be stuck with an IV. You lie on an X-ray table. It's open, so you don't have to worry about claustrophobia. Of course, if patients have back pain, you know, even 15 minutes, sometimes patients can have some pain. That might be a disadvantage, but it's quick, it's easy. Now, disadvantages. Limb positioning. If not done properly, you can get an inaccurate bone mineral density of the hip or spine. Example, on the hip needs to be internally rotated about 20 to 25 degrees to get an accurate bone mineral density. That puts the femoral neck parallel to the X-ray beam, and that's the ideal position. If you don't do that, and it's externally rotated, it's not going to be the best score. And that's also important if a patient's getting serial bone mineral density studies, serial DEXAs. I mean, if they get one study, it's rotated in, next time rotated out, there's going to be different bone mineral density. Spinal degeneration can elevate spinal BMD. So you got to be careful in the spine. You probably notice that those bone mineral densities, you know, 70, 75-year-old females or males, it looks really good. But that can be misleading. Conversely, laminectomy or scoliosis can lower BMD. A point we're going to talk about here in a minute. Majority of fractures occur in the osteopenia category. Very interesting. And it's not an accurate reflection of bone microarchitecture. Bone microarchitecture is the trabecula, the spongy bone. Okay, traditionally, diagnosis of osteoporosis, T-score less than minus 2.5 at the femoral neck, total hip, or L1 through L4 vertebrae. That has been the traditional way to diagnose it. So here, this is the diagnostic criteria developed by the World Health Organization in the early 1990s. There's 3 different categories. You either have normal bone mineral density with a T-score of -1 and above. You either are osteopenia, which is low bone mass. That's kind of the preferred terminology anymore, low bone mass instead of saying osteopenia, even though we still say it. It's between -1.0 and -2.5, and then of course osteoporosis is -2.5 and below. So the wonderful T-scores, that is the young normal. It indicates how your bone mineral density compares to that of a normal young adult. Okay? Represents the number of standard deviations from the normal young adult mean value. So the young normal, it's comparing it to all ethnic groups, white females aged 20 to 29 from this database. Okay? Even men that get this. Okay? When they get it, it's compared to the females aged 20 to 29, and that gets the T-score. Z-score, it's age match. It's indicating the bone mineral density compared to what might be expected in someone similar age, gender, and ethnicity. Okay? You use Z-scores when looking at premenopausal females and males younger than 50. T-scores is postmenopausal females. And Z-score of minus 2.0 or lower is defined as below the expected range for age. Okay? That's how we define that. Of course, there is an example of a DEXA report. This is of the spine. So if we go up here, and L1 through L4, that's where we look at the bone mineral density, and I apologize if that's hard to see. 1.357 grams per centimeter squared correlates to a T-score of 1.1, normal, okay? And I believe this was an actual patient of mine, so I believe he was 75, and Z-score 1.4. This is a right hip. So again, bone mineral density, femoral neck was 0.807, correlates to a T-score of minus 2.0, which would be osteopenia. Z-score minus 0.8. One thing that's nice on these DEXA reports that are generated, you can get a trend. And right here, they were comparing the total bone mineral density at the hip from 3 years ago to now. It's been a 2.6% increase. And in this particular individual, he was being treated with Prolia actually. And that's to be expected. The bone mineral density gains are not as significant at the hip with Prolia as they would be at the lumbar spine. And I can't remember what, he had a 9.9% increase. So that's pretty typical with somebody who's had Prolia. Indications for DEXA. Of course, some of this, if it's Medicare, pretty easy to get a DEXA. You can get it every 2 years. Postmenopausal female, of course, they're being treated. Commercial insurance might be a little different. I know one thing that can help, just a little pearl, if you're trying to get a bone density study on somebody 50 to 65, maybe even younger, get a vitamin D level, and if they have vitamin D deficiency, that'll cover it. So women age 65 and older and men age 70 and older. Postmenopausal women and men between the age of 50 and 69 based on a risk factor profile. Postmenopausal women and men who have had an adult age fracture, fragility fracture, to diagnose and determine the degree of osteoporosis. And importantly, if you're treating someone, you want to monitor the progress in response to pharmacological agents and serial exams if you're doing a drug holiday, which is important with the oral bisphosphonates, IV reclass when you take them off. Okay, now, is traditional DEXA scores the only way to diagnose osteoporosis? The answer is no, okay? And I've got the World Health Organization FRAX tool and also using guidelines from the National Osteoporosis Foundation and the American Academy of Clinical Endocrinologists. So, diagnosing osteoporosis. One problem, if you remember, I said 50% of fragility fractures occur in women with a BMD in the osteopenia range. So, what do you need to do? You need to take into account other clinical factors for fracture to get an accurate risk assessment for fracture. This will help to guide your treatment when you're sitting there with that patient in the office and trying to decide, boy, do I need to treat this patient? You know, she's got a T-score minus 1.5. You know, she's had a wrist fracture. She's also had a foot fracture. You know, what do? It's a tough call. It can be really tough. This is a chart that shows that minus 1 all the way up to minus 2.5. The gray bar indicates the number of fractures, and as you can see, there are more fractures in these women in that range as there are when you get to the osteoporosis. So that is significant. American Academy of Clinical Endocrinologists, their guidelines in 2016, if you have a T-score of minus 2.5 or below in the lumbar spine, femoral neck or total hip, or 33% radius, osteoporosis. Low trauma spine or hip fracture regardless. Doesn't matter what the DEXA says. If you have it and it's a low energy fracture, they have osteoporosis. They have poor bone quality. Osteopenia, again, that minus 1 to minus 2.5 with a fragility fracture. okay, low energy fracture, proximal humerus, pelvis, or possibly the distal forearm, osteoporosis, they've got it. Or low bone mass or osteopenia, say they haven't fractured, but they have a higher FRAX score, which we're going to get ready to talk about. National Osteoporosis Foundation, same guidelines, it's similar. And there is the FRAX assessment. So it uses other risk factors that have been shown independently of bone mineral density to increase fracture risk or have been associated with it. And that includes gender, height and weight, previous fracture, parent hip fracture, smoking, chronic steroid use, rheumatoid arthritis, secondary osteoporosis, and that's important too. What are other causes that could be causing that patient to lose bone density? Type 2 diabetes, keep that in mind. Terrible on bones, absolutely terrible. Vitamin D deficiency, premature menopause. Those are things you got to be thinking about, like why, especially if you've got a 48-year-old female, it's like, why is this person fracturing and what's going on? Hyperparathyroidism, that's another thing to think about. Alcohol use, I can speak, I know seeing people in my clinics, heavy alcohol use, terrible on bones, absolutely terrible. And smoking, of course, we all know about that. Okay, and let me go back here. So this is an online assessment, and when you fill out this and you also put in the bone mineral density or the T-score of the femoral neck, very important, it's femoral neck, it will punch out a risk factor assessment. It'll give you the 10-year probability of hip fracture, 10-year probability of major osteoporotic fracture, which major osteoporotic fracture includes spine, proximal humerus, distal radius, pelvis. So if these numbers come back and in major osteoporotic says 15%, they're not elevated. It has to be greater than 20% to be considered an elevated risk of fracture. That hip fracture number there says 5.5. That is elevated. Anything greater than 3% is considered an elevated risk of hip fracture, should consider treatment. Other technologies, vertebral fracture assessment. This can be software incorporated into the DEXA. It functions as a digital X-ray device. What it will do is determine vertebral body dimensions, looking for compression fractures. It may recognize one that wasn't previously seen, even on conventional radiographs. Some people would say, oh, I'll just get a lateral view of the spine. And that you can do that, but why not just get it on the DEXA and you avoid excess radiation? And that's a picture of what a vertebral fracture assessment looks like from a DEXA machine. TBS, trabecular bone score. So this is interesting. I've actually had some conversations with a gentleman who has this software. It's about $2,000 a year to get it on a DEXA, but it determines bone texture. And this is related to bone microarchitecture. Again, that's that, how does the bone really look? The DEXA can't tell us that. As surgeons, I know they can, being in surgery, we can get a direct look at the bone and see it. And sometimes we know it's terrible. I mean, I know Dr. Peterson, anybody that does total knees, and I've helped a bunch too, when you can take the pin, we use a pin to put in the tibial tray to cut the tibia. When you can push that in with your finger, they got pretty bad bone. That should not happen. You should be able to mallet that in. But it evaluates the pixel gray level variation in the DEXA image. It's software, again, that can be installed on a DEXA. Best utilization, patients who have a higher BMD but poor bone quality. It's in type 2 diabetes, hyperparathyroidism, rheumatoid arthritis, and glucocorticoid-induced osteoporosis. That's an example of what the TBS printout would look like from a DEXA. The top is normal, and you can see that it's kind of got that gray and white checkerboard there. That's normal. So you can see that vertebrae, that looks good. Good solid trabecula there. If you look below, That's what a bad vertebrae looks like. That's osteoporosis. I mean, there's a hole in the bone. I mean, it's just not as dense as it should be. And that means my time's about up. That's again another image of what osteoporotic bone looks like, and healthy trabecular bone. Other images, qualitative ultrasound is out there, relatively inexpensive, can be used. They usually do it on the heel or the wrist. MRI, unfortunately MRI is more expensive. And then quantitative CT scans, downside of course is high radiation exposure, but it does predict hip and vertebral body strength better than DEXA and FRAX. There's also a peripheral CT that can be done, lower radiation, that would be done at the distal radius and tibia. Just real quick, most of you know who are in clinical practice, treatments available, or we're not going to go into it, just oral bisphosphonates, IV reclass, there's Prolia, Forteo, Tymlos, and also one of the newer agents that's out, anabolic agent called Evenity. Love your bones. So encourage our patients to really take the initiative and to take care of themselves. And, if they're smoking cessation, decrease alcohol use, making sure they're getting DEXA scans. It's cost efficient, it's easy to get a DEXA, it's the best study to get initially. And as Dr. Peterson says, Own the Bone, that's through the American Orthopedic Association. If anybody's interested, they've got a lot of good resources that can be utilized for osteoporosis, and it's actually a national registry. So that's a good source to use. Just be proactive with your patients. If they have a fracture, really talk to them about, hey, we need to really check this out. Make sure you don't have osteoporosis. I didn't even touch on, making sure they've got enough calcium and vitamin D in their diet for supplementation. So just be proactive, and that's it. All right. Any questions? Yes.
I have a couple.
Yeah.
I don't see any other hands up. First off, for those that are not covered by insurance, what's the approximate cost of a DEXA scan?
Good question. I have not specifically checked here in our community, but kind of getting an idea, researching it. I mean, typically maybe $100 up to $300 at most. It's pretty inexpensive.
And the second question, why has there been this movement away from treatment for osteoporosis?
Patient fear of side effects, I think. That's part of it. Bisphosphonates, of course, the two side effects on bisphosphonate. And all these treatments are effective. They work. There's advantages and disadvantages to all of them. But in my opinion, it's patient-driven. It's, we're in an age where you can hop on the computer and, look up all these medicines, and bisphosphonates, osteonecrosis of the jaw, and atypical femur fracture. And I know I didn't go into it much, but the potential for those side effects are rare, very rare. You're more likely to break a bone than get those side effects. You really are. I mean, I tell people, and if you look at the statistics, for those two side effects, you would have to treat 10,000 patients on bisphosphonates to maybe see 1 to 4 cases of that. So it's rare. But one thing I would say, precautionary measures, anybody you're thinking about starting a bisphosphonate on, make sure they're going to a dentist regularly. Because if they have poor dental health, they're at higher risk of getting that side effect, especially if they have a tooth extracted. That's where it seems to really be a big problem, is if a patient goes in, gets a tooth extracted, and they don't tell the dentist, they might get osteonecrosis of the jaw. And what that is, if you don't know, it's a sore that develops on the gum line with exposed bone that's been present. I think to officially diagnose it, it has to be there more than 8 weeks. So I've seen it. I've seen it on a patient that was on Prolia, but she didn't tell her dentist she was on it, even after I told her to tell the dentist. So she went and got a tooth extracted. She got it. Fortunately, it healed, and she didn't have to the good thing about Prolia is it has a short half-life and it gets out of your system. So once it's out of your system, that's good. But I think it's just, the fear of side effects.
said before, so you don't have a weird spongy bone when you go into surgery for totals.
Trying to be more aware of that. You're exactly right. Being proactive and trying to evaluate patients prior to total joint replacement is very important. I think vitamin D level, making sure it's adequate. That I would love to do it on everybody, but unfortunately everybody, we don't capture everybody with that. There's actually some good, and actually Dr. Peterson shared it with me, there's some good research that suggests patients on oral bisphosphonates have less risk of revision of their knee replacements. So, anything else? By the way, that's my 15-week-old yellow lab, Ruby. She's been quite the character lately. She's had 3 bouts now of giardia, so it hasn't been fun at home. But that was us at the vet, so yeah. A lot of sleepless nights, just because waking me up and yeah. So, well, thank you. Oh, sorry. I think basically once a year, but if you're treating them, and if you get them on a higher dose, say you put them on like 5,000 units of vitamin D, and you're needing to check them, I would not hesitate in 3 to 4 months to recheck them and see where they're at. But yeah, I think once a year is what they'll cover.
All right, thank you very much.
Thank you.
So yeah, I'm Brian Duncan, if you guys don't know me. This talk will dovetail nicely with Brandan's talk on osteoporosis. Hip fractures, especially geriatric hip fractures, is not the most glamorous orthopedic topic, but it's certainly an important one and deserves special attention because it affects so many of our elderly population and so many families in our community, as we'll highlight here in a second. So these are my disclosures. I'm a partner at Orthopedics and Sports Medicine Center. I'm also a shareholder at the St. Joseph Center for Outpatient Surgery, and I work in Maryville 1 day a week for Mosaic Life Care. So none of that should affect what you hear today. We're going to talk about the epidemiology of hip fractures. We'll talk about some numbers, cost of care, and then we're orthopedic surgeons. We like to classify everything, so we'll talk about classifications of fractures. And then we'll touch briefly on some management on how we treat different varieties of fractures. We won't go into too much detail there, but we'll highlight some of the things that you may see in your roles on a day-to-day basis. And then at the end, we'll talk about some outcomes and things that we can do to improve those. I pulled this picture off of Dr. Peterson's Instagram account. There's no hip precautions there. So the hip fractures we're going to talk about today primarily affect the elderly, and most of those come from just a simple mechanical ground level fall. 90% of hip fractures occur in people over the age of 50, and 50% of those occur in people over the age of 80. Most of the fractures fall in the age range of 75 to 84. The numbers. So this is something that grows increasingly every year as our population ages. It's estimated that 350,000 hip fractures occur in the United States annually. By 2025, we expect there to be 3 million in the world. You can see that on the graph on the right, the population continues to age exponentially, and by 2050, 82 million people will be over the age of 80. So we expect this problem to continue to get worse. This gentleman's worried about the cost. He's got his mind on his money and his money on his mind. It's an incredible economic burden for hip fractures in the United States. It's estimated between $17 and $20 billion are spent alone in hip fracture care yearly. After the first year from a hip fracture, the average patient will spend $40,000 directly related to care for that fracture. This is some of our local experience. I asked our office manager pull our numbers for 2018, and I was surprised at the volume that we do here at this hospital. I knew it was high, but I didn't know it was this high. So at Mosaic Life Care, we did 334 hip fractures in 2018. The distribution was fairly even, 155 femoral neck fractures and then 170 intertroch and subtroch fractures. There are significant gender differences in distribution among patients who have these fractures. Fractures are much more common in females. Depending on what study you read, there's a 2 to 3 to 1 ratio between male and females. However, if males have a fracture, they tend to be sicker and have more complications. They also have a higher 1-year mortality after geriatric hip fracture. So moving on to some classifications. As I said, orthopedic surgeons like to classify everything, and sometimes those are fairly meaningless, but these classifications actually have some meaning because they determine how we treat these fractures. I like to think about them as intracapsular, which means basically within the joint itself, extracapsular, which means outside the hip joint. So the intracapsular fractures are typically your femoral neck fractures. Those are your subcapital femoral neck, your mid-cervical femoral neck. Basicervical fractures are a little bit of an outlier. They are technically intracapsular, but they behave more like an extracapsular, and so we treat them that way. Your extracapsular fractures are your intertrochanteric fractures, your greater troch fractures, which rarely need surgery, and then your subtrochanteric fractures. We'll talk about the intracapsular first. The main difference between intracapsular and extracapsular is that in the fractures that happen of the femoral neck, they violate the main blood supply to the femoral head, which puts the patient at risk for avascular necrosis if that femoral head blood supply is not able to withstand or recover from that fracture. And again, these involve mainly the femoral neck fractures, your subcapital and transcervical. The primary blood supply to the femoral head is the lateral circumflex artery, and those on the picture on the right, the branches that are affected are those ascending cervical branches which go up to supply the femoral head. When the femoral neck fracture is non-displaced, we have some options. In those fractures, the blood supply is typically preserved because that fracture does not violate those arteries. And so we can proceed with a smaller operation, which is percutaneous screw fixation. So through a small incision on the outside of the hip, the patient can have these screws placed. Usually we place them in an inverted triangle with 1 screw in the inferior neck and then 2 screws more superior. The problem with these fractures, and you have to take this into account when you're making these decisions, is the patient has to be limited weight bearing postoperatively. So you have to consider their mental status, their ability or willingness to comply to those limitations postoperatively. For fractures of the femoral neck that are displaced, that blood supply is compromised. So we typically choose some arthroplasty surgery to treat those fractures. We do that because of the high risk of avascular necrosis in that femoral head. There's been some growing interest or an increasing debate about whether we should be doing hemiarthroplasties versus totals, and I think the trend is in our younger, more active patients, you're going to start seeing more totals. The difference between the two is that hemiarthroplasty just replaces the femoral head side of the joint. Total hip arthroplasty replaces the femoral side of the joint as well as the acetabular or the socket side. This is a bigger operation, but it does allow for immediate weight bearing. Risk of dislocation is present, so again, you have to be careful about making decisions about approach, especially in patients who are demented or have mental status issues or compliance issues. Again, total hip arthroplasty is trending up as far as treatment for displaced femoral neck fractures. We tend to do this in our younger and more active patients because they have a better long-term outcome than hemiarthroplasties. Risk of dislocation is a little bit higher for total hip arthroplasty after a femoral neck fracture than standard total hip arthroplasty for arthritis. Moving on to the extracapsular ones. So these are your intertroches and your subtroches. Fractures occur. The intertroche is a fracture between the greater trochanter and the lesser trochanter. Subtrochanteric fracture is below the lesser trochanter. For intertrochanteric hip fractures, there's several treatment options. I tend to look at these as I look at the X-ray and determine whether I think the fracture is stable or unstable. For stable intertrochanteric hip fractures, you can do a sliding hip screw and side plate. That's probably the gold standard still. It allows that screw that goes into the head of the femur will slide in the barrel that's attached to that plate, which will allow that fracture to compress into a stable position and allow healing. This implant does allow for early weight bearing, which helps our patients mobilize and prevents medical issues like pneumonia and such. The other option for intertrochanteric hip fractures is cephalomedullary nail. This is an implant that goes actually inside the bone and is a load bearing or load sharing device. It also has a lag screw that goes up into the femoral head that is allows the fracture to have a controlled collapse into a stable position. Typically, this can be used for stable or unstable fracture patterns and is probably a better choice than poor quality bone. This also allows for early weight bearing. Subtroch fractures are not something we ever really want to see when we're on call because they're not fun to do because they're really challenging, especially in the elderly population with poor bone quality. They typically require a long cephalomedullary nail or another long intramedullary nail. And they're problematic because they're difficult to reduce. A lot of times we have to open these fractures through big incisions with blood loss. You see these cables in this X-ray where they're trying to hold that fracture reduced. The deforming forces for this fracture are the iliopsoas, which tend to put the proximal fragment into flexion, and then the gluteal muscles, which tend to abduct the fracture. So those are the things you're fighting in the operating room, trying to get that thing reduced. And this X-ray is an example of one that's not so well reduced, and that's going to probably lead to problems like non-union and implant failure. Moving on to outcomes. I would argue that hip fracture outcomes historically have been as bad as some cancer diagnosis outcomes. If you look at the 30-day inpatient mortality for geriatric hip fractures, it ranges anywhere from 3 to 10%. Again, a little bit higher in males, a little bit lower in females. 1-year mortality rate ranges from 14 to 36%. So you think about that. A third of your patients in some studies are dying within 1 year from their hip fracture. A lot of our patients lose their independence or lose some level of function. 50% of them are not able to walk independently after hip fracture. They require a cane or a walker or a wheelchair even. And almost 2/3 of our patients two-thirds of our patients are unable to return to their pre-injury level of independence after hip fracture. So someone who's living in assisted living situation may not be able to go back to that and may have to go to skilled care. Someone who's living independently may have to go live with family members or assisted living. Factors that are associated with increased mortality are, as we said, are advanced age, male gender, major comorbidities like COPD, heart disease, diabetes. Anyone that's already living in a institution like a long-term care facility, and then psychiatric illness is also increased with, or a factor associated with increased mortality. How do we improve these outcomes? Studies have shown that surgery within 48 hours of hospital admission improved mortality rates in hip fractures. Our goal at this hospital is to get them to the OR within 24 hours. Most of the time we can do that. The exceptions are typically patients that are on blood thinners that make it less safe. So those are the ones that fall out. Taking care of these people requires a multidisciplinary approach that starts in the emergency room with the ER doctors. It involves dietitian, nutritionists, physical therapists, nurses, orthopedic surgeons, people that do osteoporosis care. All these people are required to get good outcomes in these difficult patients. Multimodal pain control postoperatively is important. You can't just flood these patients with narcotics. You have to do other measures to help control their pain so that you don't affect their ability to mobilize or don't affect their mental status and cause other complications. These patients require intensive physical and occupational therapy. The goal is to regain whatever pre-injury level of function they were operating at, and that requires lots of help from our therapy staff. And the main way to improve outcome, as Brandan touched on, is prevention. Osteoporosis screening, fall prevention, keep helping our elderly patients stay more active and improve and maintain their joint health. In conclusion, geriatric hip fractures continue to be a major public health issue, costing lots of money and affecting lots of lives, and this will continue to grow in the next decades as our population ages. The majority of hip fractures will require some measure of surgical intervention. You're probably going to be seeing more total hip arthroplasty for femoral neck fractures in younger active patients because they have better long-term outcomes. Taking care of these patients requires multiple team members, multidisciplinary approach to optimize their return to function, and osteoporosis treatment and fall prevention can help prevent these fractures. Any questions? Yes, ma'am.
Any idea why males have the lesser outcome?
They tend to have they tend to be more sick when they come in. So they have higher rates of heart disease, higher rates of lung disease. So they're sicker when they come in, and so they have more comorbidities, and then that affects their mortality. Any other questions?
You like to categorize what makes the difference between the different fracture sites? Is there like different ways?
Like different mechanism? Not that I know of. I think it's probably how they fall or what they hit first, but there's not a system like an ankle fracture. Ankle fracture has a system that categorizes that, but I don't think there's one for hip fractures.
The topic is, for me, is compressive neuropathies of the upper extremity, but really this amounts to carpal tunnel syndrome. Compressive neuropathies, carpal tunnel, cubital tunnel syndrome, tarsal tunnel, et cetera, et cetera. But carpal tunnel represents 90% of the compressive neuropathy. So that's mostly what we'll talk about. My disclosure, I'm an investor in the Surgery Center here in St. Joe, and also Orthopedic Properties, which is basically our office building. So definition, the definition is all over the place, but in general, it's a constellation of symptoms secondary to compression of the median nerve in the carpal tunnel. So for those of you who don't know the anatomy, the median nerve courses up the arm, runs through a tunnel, a fibroosseous tunnel in the wrist. The floor of the tunnel is the carpal bones. The roof of the tunnel is the transverse carpal ligament. And the symptoms are a constellation of symptoms, and you can see just about anything. You may hear or have heard people talk about numbness and tingling in their fingers, and that is one of the symptoms. But really, at least in my practice, the primary symptom is hand pain or wrist pain of any fashion. So yes, it can cause numbness and tingling, but anytime someone has hand pain or their hand hurts, I start thinking carpal tunnel syndrome. So the history, Piaget first described it in 54. The first carpal tunnel release was performed in 33. Phelan is the one that really popularized it in the 50s, and we all probably know Phelan's test through a series of articles. And the first endoscopic release was in 1985. Is this a pointer? Yeah. So, you know, we all love the brachial plexus. It's the median nerve, comes off the posterior or the lateral cord, and as it, no, it's not working, comes down, runs through the forearm all the way up, and then through the transverse carpal ligament here. Oftentimes the sensation in the palm is preserved because there's a branch of the median nerve that comes off proximal to the ligament, and that preserves sensation in the palm, which will explain why people will get numbness in their fingers rather than the palm. So oftentimes, at least I'll get complaint or questions from people of why is their palm not numb but their fingers are. Others, oftentimes people complain of their whole hand going numb, even though the little and ring fingers are technically not involved in the carpal tunnel syndrome, or that's the ulnar nerve territory. And there's an explanation for that, and I'll show that in a slide a little bit, this next slide here. So median nerve, of course, is up here, transverse carpal ligament is here. This is the cross section of it. The median nerve runs with all the flexor tendons of the hand. And the floor of the Guillon's canal, so this is ulnar nerve over here, the floor is actually part of the transverse carpal ligament. And they've shown in MRI studies that when you release a transverse carpal ligament, Guillon's canal, which is where the ulnar nerve is running, actually opens up too. So sometimes when you'll get an EMG, and maybe JT can talk a little bit about this later on, EMGs are this black art that there's only like a few people in this world understand. But it's not unusual, and I will often see sometimes people will talk about, I'll get a report that talks about Guillon's canal, or maybe even they can't exclude compression of the ulnar nerve at the wrist. And at least in my practice, I tend to not pay much attention to that. Unless if they really have true symptoms or a reason to have Guillon's canal compression. Release their transverse carpal ligament, do a carpal tunnel release, and those people do great. So nerve-wise, you know, the nerve is composed of different fascicles, average number of 24, and the sensory fibers, I don't know why I put this in here, but the sensory fibers outnumber the motor fibers 9-to-1. One of the things that maybe JT will talk a little bit about is that sensory fibers are more compression sensitive. So oftentimes people will get symptoms, pain, numbness, before they start getting motor symptoms. So motor findings is a really late find. Especially when you look at, you see the textbooks where they'll show thenar atrophy, right? Well, that's a really late find. The physiology, the normal resting pressure in the transverse carpal ligament is what I found was 2.5 millimeters mercury. I've seen that all over the board. It can be up to 10 in resting. Through different excursions or wrist motion, that pressure changes. So in wrist flexion, it can go up to 3 to, I put 6 here, but I've seen 10 times the normal amount. Ultimately, the pathophysiology is reduced epineurial flow or blood flow to the nerve, and there's many reasons for that. There can be vascular, there can be drawing a blank on the word, like diabetes or other constitutional or systemic problems that decrease blood flow to the nerve. It's the most common compression neuropathy. Common age is 51. It's most common 40 to 60. Females are more affected than males. More common in industrialized societies. And interesting, I just read a paper when I was doing research for this topic. It seems to be more common in Europe than the United States. We don't really know why. It may be they find it earlier or more often than we do. Maybe they're looking more, but more common in industrialized societies. Very often bilateral and more common in the dominant arm. Symptoms, pain. That's the biggest one, pain. Numbness and tingling, usually worse at night, worse with gripping. I'll let you read the rest of them. There's documented reports of it causing forearm pain. I think in 1999, there was a series of case papers that reviewed the literature and showed that it can cause symptoms almost anywhere in the upper extremity. So vague forearm pain, shoulder pain, that was first described in 1977. Isolated shoulder pain as a presenting complaint of carpal tunnel syndrome is in the literature. And I didn't know that until I started reading for this topic. I think we've all kind of been told that if they don't have numbness and tingling in their fingers, it doesn't exist. The numbers I saw was, I think 1% of carpal tunnel, the presenting complaint can be shoulder pain. And anecdotally, I've seen that in our office. Brandan, my PA, he said he just saw a patient back that her presenting complaint was a vague posterior shoulder pain, and it went away after their carpal tunnel release. So I find that kind of interesting. Symptoms, numbness at night is almost pathognomonic. So even though I say that numbness or pain is the most presenting complaint, people who really have it, and you can almost nail it, is their hand goes to sleep at night. They wake up, they got to shake it out. They feel like their hand is swollen. Other common complaints I hear is that their hand feels bruised. Or I've had patients come in and say, yeah, my hand's swollen, and I'll look at it and, no, it looks normal. And, no, doc, it's really swollen. It really is. So and the whole reason is this decreased perfusion pressure. Numbness doesn't have to be exactly anatomic. Thenar wasting is a late sign. The tests we have, or the signs we have, Phelan's sign, Tonella signs, and Gertken's direct compression test. Gertken's is really probably the best clinical test you can do, but we all know Phelan's. The sensitivity and specificity is all over the board, and we don't really know why that is, but it's probably because everybody does it differently. You know, you'll see in a textbook, you'll see Phelan's, people say, well, this way, then you do it this way, then you do it this way, and it's really kind of variable. Etiology, in general, you can categorize it as a reduction in canal size, and that can be due to trauma or osteoarthritis, or an increase in the volume of the contents of the carpal tunnel. So synovitis, which causes inflammation and swelling, and gout, blah, 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 those different things that increase the volume of the canal. And then very rare is congenital abnormalities, and we won't get in that. You can read that there. Associated with many different factors. Demographic, as we talked about, more common in industrialized societies, increasing age, female, genetic. People will have different size of wrists, and they talk about this square wrist. I don't know that I've ever seen a square wrist, but genetic can cause it. Medical conditions, we all know that diabetes, thyroid, and other things can influence the development of it. Injury or trauma, distal radius fractures, that's what I'm getting ready to do. There is an association between that and then pregnancy. We all know that sometimes, people that in pregnancy, they can get really, really, really miserable. And the diagnosis, a lot of times people will say the diagnosis is based off of an EMG, and it's really not. It's based off of the history. The EMG is an extension of your physical exam. And although I'd like to say that you know, EMG is the only way to diagnose or whatever, because it's also a test that my wife does, and please send them, you know, et cetera. But it really is an extension of your physical exam. And there are people that'll have symptoms with a normal EMG, and people that have normal EMG and no symptoms. And so you can't just say, aha, the EMG shows this, and that's therefore what it is. I've done releases on people with a normal EMG. I've done releases on people with a EMG which showed denervation, and they had no symptoms, and that's been described. Pretty rare, but it's been described. CT, MRI, and ultrasound, still in its infancy. You can measure the cross-sectional of the area of the carpal tunnel and by EMG or by ultrasound, MRI, but it's really in its infancy. You may just hear some things about that, but nobody's really doing that. I don't know, have you ever, hey JT, have you ever?
We will usually look at the nerve under ultrasound.
Under ultrasound?
Especially if the EMG and the history doesn't quite add up.
Yeah.
It's usually the morphology of the nerve.
Yeah. I've never really been good at measuring the canal size and stuff like that, but yeah. So Phelan's test, you know, once again, here's, I guess there's the description of it. Wrist is flexed 90 degrees, and if they have symptoms. And oftentimes, I think Phelan's originally described it as 60 seconds, but sometimes it doesn't take long for them to get symptoms in their finger. Honestly, I really don't do Phelan's all that often. You hear the story enough, you just kind of know what it is before before you do any tests. So Phelan's test, this is how they're shown to do it, but also you'll see wrist extension, a Tinel sign, tap on the nerve causes tingling and elicits symptoms in the median nerve distribution. Gertken's compression test, this, as far as what I've looked at, is the most sensitive and specific test, and it's direct compression on the carpal tunnel. The challenge is getting it right on the transverse carpal ligament, and that is just distal to the wrist flexion crease. So if you go there, that's where it's going to be at. But once again, I see people, I've seen books where they'll put the pressure here or out here, and I think we're all kind of doing it differently. I think we'll explain why there's so much variability. 2-point discrimination. If I'm really trying to figure out, sometimes I'll do this. 2-point discrimination, basically, I just take a finger clip like this, and a static, if someone has more than 6 millimeters, or I'm sorry, the normal sensation would be less than 6 millimeters, but moving, if you're moving it around, you know, I got that backwards, don't I? Mulberg, you described it as static, less than 6 millimeters. I think I have that backwards. At any rate, if they have an increase in the distance between two fixed points in testing sensation, that's an indication that median nerve compromise exists. I think I did this maybe 2 years ago. Once again, nobody really does it. Siemens-Weinstein tests, you probably, I don't know, maybe someone knows about this. You'll find this in museums. Basically, it's a monofilament of different diameters, and they go from small to large, and it's kind of how hard you have to push on someone before they'll feel it. I think maybe we had this in our office, and I know for a fact it probably got thrown away 10 years ago. What else we got? So physical exam findings, sometimes you'll find weak thumb abduction, because that's what it really does. And a lot of people, the thumb is really confusing. So this is extension, extending the thumb, and this is abduction. It's moving it out into the palm. So if you're really examining somebody, they might be weak. But once again, that's a late finding because motor fibers are involved last. Okay, the tests, blah, the sensitivity and specificity. I won't get into the electrodiagnostic studies much. I'll let JT do that. But in general, I think of this as categorizing a mild, moderate, severe. There's really no standard as to what constitutes mild, moderate, severe. There are, I guess, ways of categorizing that. But is that right? There's really no global standard, right, JT?
No, I mean,
People do.
I think you can do like combined sensitivity and things for a higher sensitivity.
Right.
Yeah.
Yeah. So ultimately, mild, you're just getting the sensory fibers. Same thing with moderate. And when you start getting into the severe, that's when you start to get denervation. But what I haven't really had a good explanation for as why, if someone's in the moderate category and I do a carpal tunnel release on them, oftentimes a follow-up EMG, if you have the opportunity to do it, it'll tend to revert to only mild. It doesn't go away. So if you're not getting denervation in the moderate category, then why doesn't it go back to normal? I don't know. I think there's some demyelination, things like that that's kind of beyond this topic. But in general, I think electively waiting until it's moderate is a disservice to patients. And I've heard people say, well, it's not bad enough yet. I've heard other physicians say, well, it's not bad enough yet to do. It's kind of like saying, well, your cavity's not big enough to fill until it starts rotting your tooth. And I'll freely admit that I'm more aggressive than a lot of people in doing carpal tunnel releases. If they have symptoms consistent with carpal tunnel, I will do their release. It doesn't matter what the EMG shows. So differential diagnosis, you get other compressive neuropathies elsewhere, pronator syndrome, anterior osseous syndrome, and there's the rest of them that you can read. Non-surgical treatment, in general, in my experience, only do this if they're in the mild category based off of EMG. You really are doing a disservice to someone if you're in their moderate category and you're putting them in a splint. Maybe that's okay if they're pregnant or it's a really acute onset. Maybe someone spent the weekend painting their house and they're really miserable and they had 0 symptoms before. Okay, then you can do it. Splint, physical therapy, NSAIDs, steroids, diuretics. Steroid injection, you'll read about this. This probably has been done maybe once in St. Joe in the last 10 years, and I did it on myself. I've never done it on a patient. I don't know any of my partners that's ever done it on in a patient. I have seen people that have had this done elsewhere, and they had an intraneural injection, and that's a disaster. So I don't know, maybe with ultrasound, maybe you can do it, and you probably have done it. Yeah, exactly, that is a great thing. I just haven't been I've got an ultrasound in my office too, and I use it on some occasions. So I think you can. My understanding of steroid injection is that there's really no long-term benefits. And after about a month, the benefits go away. So the pregnant patient that can't have surgery, or someone who can't have surgery for other reasons, an injection is a great option. But I don't know that I would do it routinely. So limited evidence shows significant short-term benefit from splinting. Moderate evidence shows short-term benefits from oral steroids, and in general, non-surgical treatment may be allowing the nerve damage to progress. And there really is a tendency to earlier and earlier surgical intervention, right, wrong, or otherwise, that's what's happening. So how can you predict this? This is a chart that I'd found in one of the review articles. And in general, if you have 4 of 5 of these, then non-surgical treatment has a 0% success rate right here. So if someone, and these are the questions I'd ask, that I ask, have you had symptoms more than 10 minutes or 10 months? Do they have constant paresthesias? Do they kind of have numbness all the time? Flexor tenosynovitis, Phelan's test, and are they older than 50 years old? So I actually find this a pretty useful chart in my practice. Surgical treatment, open carpal tunnel release. It was first done back in the 50s. There's also endoscopic carpal tunnel release done in 1985. With endoscopic, you can do 2 incision, you can do a single incision, that's distal, single incision proximal. I do single incision proximal. I do almost all of mine endoscopically. Revisions, you can't do endoscopically because of the scarring of the nerve that takes place with the nerve, or the scarring of the nerve that takes place after you incise the ligament. I won't try to convince you that endoscopic is any better than open, because the literature shows the ultimate outcome is the same. However, there's a number of reports out there that patient satisfaction is higher with endoscopic. It is less painful. So open release, historically, it's the gold standard. Pros, it's fast, easy, and cheaper. Yes, it is more expensive because we use more equipment in the operating room. The cons, longer return to maximal grip strength. And the reason for that is that you actually have to transect the APB muscle when you're doing the open approach. And I'll show you a picture later on that shows that through the endoscope. In my hands, it's not faster. When I first started doing endoscopic, it took quite a bit longer and it was quite a bit more frustrating. And now in my hands, I can do an open or an endoscopic release just as fast as an open. So open carpal tunnel, you see the different types of incisions. This is kind of the older style one. Most orthopedists or most people doing them now are doing through more of a limited incision right in the palm. But the palm is really sensitive, and that scar is sensitive for a long time. So the endoscopic, so with endoscopic release, early return to maximal grip strength. I see in my practice about a maximal grip strength return about 1/3 of what it is open. The cons, longer surgical time, more expensive, more technically demanding. It's pretty anxiety provoking dissecting down to the median nerve kind of blindly, and that's kind of how it is. When I started doing them, it was pretty anxiety provoking, at least when I started doing them by myself. We did them in training all the time. So 2-incision technique, here's kind of a picture of what it might look like. This is the procedure that I had just 4 weeks ago. So I'm 4 weeks out from a bilateral endoscopic. I wanted mine done endoscopically, so that's how it was done. And I'll tell you, anecdotally, that incision right there is painful. It's the worst. It's absolutely the worst. It's right there. So like I said, I'm 4 weeks out, and I've basically got normal grip strength now. I can do anything I want. So single incision technique, this is what I do. Through the scope is here. We stick this down in the carpal tunnel. There's a little blade that pops up there, and we release the ligament with a knife through the scope. Kind of a diagram of the single incision technique. And this is what it looks like through the scope. So the scope is in the carpal tunnel here. Here's the transverse carpal ligament. We're looking up at the top or on the under surface of it. And this is what it looks like under release. So here's edge of ligament here, edge of the ligament here. And this is that APB muscle that lives over the top of it. So the APB muscle actually inserts on the ligament itself. And you have to transect that in an open one to get to the ligament. And that then will explain why people will have pain in their palm, or pilar pain is what we call it, pain right here and pain right here, because that muscle, mostly on the thenar eminence, because even endoscopically, that does get damaged a little bit, and it does get stretched out a little bit, so people can have pain there. So what else? So difference in the surgical incisions. This is a patient that I did endoscopically, and this was done open elsewhere. They had this gigantic incision, which I'd say that this is probably not even, that incision is not even routine in most people's hands today. But this is the incision they use, just a tiny little incision right there. You keep that incision out of the palm and it's less painful. So the postoperative course, grip returns to maximal in 3 months. Successful and done early. Overall, excellent results. MRI shows that the canal does open up when it's released, and the pressure measurements are significantly decreased after carpal tunnel release, after a release of the transverse carpal ligament. Outcome, endoscopic versus open. There's controversy, but really long-term wise, there really is no difference. There was an interesting paper out of Penn State that I read that they convinced people to do one side endoscopically and one side open, and functionally the differences were not the same at a year, or were not really any difference at a year. Patient satisfaction and perception was a lot better. This is not that article, but this is just a review that I had found. There's controversy between the two techniques. Both are very successful. Conflicting result during return to work, and endoscopic has early grip strength and less scar tenderness, but really no long-term difference. Is this the one out of Penn State? I thought I had it in here. No, that's annuloplastic surgery. Yeah, this is one out of Penn State. A prospective randomized study. The patients served as their own control, and the endoscopic carpal tunnel had greater satisfaction scores, but no really difference in outcome. So complications, yes, you can transect the median nerve. Never done it, never seen it. My mentor at KU has seen it. You can get hematoma, swelling, recurrent branch injury. It is amazing. So the recurrent branch of the median nerve comes up here and it innervates the thenar eminence. And if you look at it in the books, the textbooks, it's right under the skin and it's right there. It's amazing more people don't cut that in the kitchen with knives in their hands. It's really close by. So late, you can get RSD, hypertrophic scar, median nerve neuritis, and the rest of the things. I do a fair number of revisions. I can't really, the ligament does kind of heal back together with scar, but it really doesn't compress it again. Most of the symptoms from recurrent carpal tunnel is due to scarring and fibrosis and other things like that. So it really is more of a neurolysis rather than releasing of any sort of compression. AOS, Academy of Orthopedic Surgeons, has a clinical practice guidelines. And here's a couple of the summaries that I found interesting out of that. And this is kind of leading more towards earlier surgical release and less conservative management. If people have symptoms more than 6 months, I'll offer them a splint, I'll offer them conservative management, but almost never do it. Final points with surgical release, they only relieve the mechanical components. They don't address the biochemical and the pathophysiology, the endocrine and hormonal aspects of it. Final points with surgery, the real goal is to prevent progression of the nerve damage. It most of the times makes their hand feel better, but what I tell patients is the real goal is to prevent progression of the compressive neuropathy. Symptoms generally improve, trend towards early release, and I think patients have a faster recovery with endoscopic, but that's my personal bias. So this is a video of me. So when I had mine done, I had it on a Monday. I came back to work on Tuesday, did clinic. I operated that Friday, and this was 2 days post-op, doing a Lockman exam on a patient. And I don't know if I can play it. But this is a Lockman exam on a patient that I saw that had an ACL reconstruction. And so you can see she's actually a little loose. She has a little bit of anterior translation. But I was able to do a Lockman's exam. And that requires quite a bit of grip strength to do it. So that's what I got. Any questions? Yes?
Yeah, you were talking about the scoring system you use in the office. One of the points there was on the flexor tenosynovitis.
Uh-huh.
You mentioned triggering of the digits. What is that?
So trigger finger is a stenosing tenosynovitis. So the tendons that run the fingers, they run through a canal. And around there's this synovium. And when people have inflammation of the tendons in the synovium, they can get trigger finger. And that's what I'm talking about, triggering of the digits. There's a high association between trigger finger and other stenosing tenosynovitis like de Quervain's and carpal tunnel syndrome. So, other things? Yes?
If the EMG isn't necessarily a fragmented part of decision-making, or a whole part of decision-making, is it required for surgery?
I don't necessarily require it, at least in my practice. If people have symptoms, I always like to have a nerve study to make sure it's not a cervical radiculopathy or a cubital tunnel also. Most people probably order it. Most people do want it because it's objective evidence. It's kind of a test that says, yes, surgery is needed or not needed. So, but in my practice, if someone is, if they have symptoms and they can't tolerate the nerve study, it's not really a overly fun study to have. If they really object to it, I've done it without, Anything else? Yes? You know what? I've never run into that. I've never, I guess I should say, I've never heard of it not being reimbursed. And those that have pre-authorizations, I've never come across it. Anything else? Cool. Thank you.
All right, we're going to stay on that, again, similar talk here. And our next speaker is going to be John Gertken. How long have you been at Mosaic now?
7 years.
7 years,
Yeah.
so wow. John did his medical school training down at KU, and then residency at Mayo Clinic, and then fellowship at the Kansas City Bone and Joint Center. So we have an amazing, as most of you guys know, physical medicine rehabilitation group here. And John's going to kind of get us started talking about the ultrasound guided injections. Should switch over there.
Do I need to? Are we wearing the mic?
So the microphone goes to the back
Oh, it
there. It
does,
doesn't go
okay.
through the room. It just goes to the recording.
Okay.
Is that okay? All right. Well, thank you, Blake. This is a great opportunity. I'm really happy that this was organized, and thanks, Kate, because, you know, just having a collection of everybody to get their collective wisdom about musculoskeletal issues is helpful. The talks before actually are a good segue, and Corey's talk especially will hit on a couple of things that he mentioned. We obviously have slight difference of opinions on conservative versus surgical management. I don't do nearly as many surgical releases of carpal tunnel syndrome. Anyway, if I look a little tired, it's because I have 3 kids under the age of 5, and everyone decided to have nightmares last night. So note to self, Exorcist is not a family movie, even if Netflix says so. So with that, we'll get started. My talk's about ultrasound-guided injections in musculoskeletal medicine, and a lot of this will be images, and unfortunately, I don't have any disclosures, so that is unfortunate. The objectives here, we're just going to do a brief cursory review of ultrasound. I'll discuss some of the advantages of the procedure with guidance, and then we'll just review some examples. And if anybody has any questions, we'll have time at the end, but you feel free to ask as we go too. So this seems simple and silly, but what is ultrasound? It's non-audible sound waves that are high frequency. They're out of our range. And the recognition of them is important, but discussing how it works is, I think, kind of interesting. Basically, what the ultrasound machine does is, and through the transducer, there's a piezoelectric effect, which is essentially it's taking electrical current, running that through the transducer. The transducer then vibrates these crystals. So yes, we use crystals in our modern day medical practice, but these crystals vibrate and produce ultrasonic sound waves that then are directed through a medium, which is the ultrasound gel, to a target, which is the tissue that we want to look at. The sound waves then interact with the various tissue consistencies and helps produce the reflection. The echogenicity, which is the extent to which these structures reflect these sound waves, define what we're seeing and the difference between bone or tendon or other surfaces. And the echogenic nature of those is how we tell the difference between those tendons. So then the transducer is interesting because it's both sending the signal and receiving a signal. When it comes back, the sound wave is then in process converted back into electrical energy. And then the big machine you see there does a lot of what it's doing is analyzing and processing those and then creating a visual image. As we will see, the technologic changes have been amazing in the last even 2 decades for what an ultrasound machine can do. So my staff knows they call me Batman because I have this affinity towards bats after one got into my house and then I fell down my stairs trying to hit it with the tennis racket. So anyway, the bat analogy in ultrasound was I couldn't resist. But it was an interesting history. A priest and physiologist in the 1700s was interested in why bats could navigate at night. So he ran experiments with covering their eyes and basically came to the conclusion they can see with their ears. Now, it was interesting. It took about 150 years before we could figure out exactly how bats use echolocation, but it was their sound was finally able to be recorded in a lab in the late 30s. And then, of course, most of us know about sonar, which is sound navigation and ranging, and this was utilized especially after the Titanic. There was, for some reason, an interest in finding big things that might strike ships and sink them. So this accelerated in World War I and World War II, of course, as technology always does for military purposes. But they were able to really use this in a wide variety of things in World War II, for instance, detecting defects in ships or crafts and munitions. And those type of technologies, which had to be condensed and used in enclosed spaces, directly led to medical diagnostic imaging. First used in late 30s, or at least first documented as the first major clinical usages. A Austrian neurologist was looking for brain tumors, basically looking at the size of cerebral ventricles, and so immediately became clear that this was going to be a very useful medical technology. And then in the late 50s, a published report differentiating ovarian cysts from carcinoma. In the 70s, start to see real-time handheld transducers and scanners, and then the advances as we most are familiar colloquially through obstetrics and cardiology. But really, musculoskeletal ultrasound has become most useful and accessible in the 21st century. So it's a modern part of our practice and has become a huge part of our practice. So it's our ability to visualize and safely make tissue diagnoses and perform interventions at bedside for the treatment of pain. And this is a picture of a needle going into the subdeltoid bursa. We'll have plenty of examples of what we use. But basically what I'm going to talk about then is some of the reasons for why we think it is a useful technology and how it helps us in our practice. Those are some of our objectives. So with regard to accuracy, it's a steep learning curve. It's not easy to just pick it up and start using it. And so I think that keeps some people from utilizing it in their practice. But the real-time needle visualization is something that gives a provider a lot of confidence to tell their patient what they're doing. And it gives the patient a lot of comfort in knowing that what you say you're doing, you're actually doing. We've found that not only does it help in accuracy for injections, but the diagnostic value of the injections has become a useful bedside test. So when in our practice, we see a lot of people with vague pains in the back or buttock or hip, and it's helpful to be able to isolate a pain generator. So you can perform an injection, and if you're using an anesthetic, you inject the hip, you can examine them pre and post injection, and voila, we found the hip problem. We can dig further into it, and it becomes not only a treatment but also a test so that you feel more confident in ordering advanced imaging or referring on to surgery if necessary. Obviously, differentiation of soft tissues is the main thing that's helpful. We can see these different types of tissues, and we'll go into some of this. Identification of things you don't want to hit and identification of things you do want to inject. So it's more accurate than palpation guidance, and many of the studies are directed at demonstrating that fact. In a variety of soft tissue targets, it makes it more usable than fluoroscopy because you can see the soft tissue target. But many of the studies show ranging, physicians we're not always known for our modest nature, so we are often a little more confident in our abilities to inject the things that we say we're injecting than cadaveric studies might indicate. So even joints like the AC joint, which surprised me, but some good studies show that even experienced injectors are only hitting this 40% of the time. So this is a very superficial injection that seems like it should be easy, but there's a variety of reasons why some of these aren't as easy as we think they are. In experienced injectors, ultrasound approaches 100% of accuracy in cadaveric studies. Now that's not everybody, because not everybody's an experienced injector, but in general, for the common injections, it certainly improves our accuracy and in many cases can make it a certainty. These are just some images, a radiograph, and then showing the ultrasound correlate of a AC joint and where that needle would go. And then a glenohumeral, a picture here of the glenohumeral joint. And what's nice is the asterisks you'll see. One is the labrum, so you can inject the shoulder without hitting the labrum, which is most people will thank you for. But also you can see that rim with asterisks is, and I guess our pointer doesn't work, but here is cartilage, so you don't want to inject that either. And so I was always taught to, you'll find bone. Sometimes in certain injections you'll find bone and kind of walk off as a way that you would do a non-guided injection. And when you're finding that bone, you're oftentimes at a joint going through something that's kind of important to people. So now so just another quick mention is that aspirations are obviously more, they're easier to get more fluid off when you have ultrasound guidance to find that. And localization of tears in the tendon. So when Pete's going to talk about regenerative medicine, but if you want to find the tear where you're going to inject your expensive PRP, then ultrasound is really helpful for real-time finding that tear and injecting it accurately. This picture, this is a part that's where, you know, Corey was talking about. Generally, I agree, injection is not a long-term strategy for carpal tunnel. You can fix it very easily with surgery and more effectively. We have, in our practice though, we see a lot of people that they're on blood thinners and can't come off. They're ill and they can't tolerate surgeries of even a minimal nature. They're pregnant. There's a million reasons why they may need an injection in our practice and can't have surgery, or there's just some people that no matter what you tell them, they will not have surgery. But this is an example of the way that we would do an injection. You see a median nerve here. And by the way, ultrasound is helpful. I think there's still some argument over the diagnosis of carpal tunnel syndrome under ultrasound standards for diagnosing it, but it's a nice adjunct because when those electrophysiologic findings are off and the patient's story is a little bit atypical, you can see the nerve, and not in these images per se, but if you're doing diagnostic ultrasound, which I'm not really talking a whole bunch about, but you will see a honeycomb appearance, you'll see enlargement of the nerve, you'll see fascicular enlargement, even if the nerve itself isn't larger. And so some of the pathophysiology that Corey was talking about, you'll see on ultrasound. Then you can direct your needle just to the nerve, and you'll see I'm injecting a little bit deep to the nerve, a little bit superficial here. You can create a nice little target sign around that nerve, providing what we call hydrodissection of the nerve, which may, in mild cases, free it up from overlying tissues that are sort of aggravating the nerve. And we've seen, just sort of anecdotally, I don't know that I have great studies to prove it, but a lot better response than when this is done by palpation. But there are some studies, Rochester, Minnesota, there was the registry in Olmsted County looked at least symptomatic improvement after guided injection versus palpation guided. So safety, accuracy, we hope begets safety. Inadvertent injury to vascular or nerve or other tissues that you don't mean to, that's one of the main benefits. One study I looked at showed 1/3 of non-guided hip injections were striking a femoral artery or femoral nerve. We can avoid that. We can avoid pneumothorax, which still happens when you're giving trigger point injections. What I find more often is that people are scared they're going to cause a pneumothorax, so they just don't inject very deep and inject their medication into the subcutaneous tissue. Well, in ultrasound, we can make sure that that is done safely and accurately. But then, as I alluded to earlier, even the less sort of devastating side effects, just injecting into someone's tendon or into their cartilage can be avoided. And many studies demonstrate less procedural pain, which correlates with better patient satisfaction. One of the things I wanted to throw up here, I do a decent amount of Botox injections, and on the top right of the screen you'll see that's the sternocleidomastoid, the muscle that turns your neck, and it's a thin little muscle, but below it is some pricey real estate of the carotid artery and jugular. So I would not, after using ultrasound as much as I do, I would never want to do this under palpation guidance because of how close it is to these arteries and this artery and vein. And so you can, with Botox or whatever you're injecting, you can be sure that you're being safe when you're doing it. There's no ionizing radiation, so it's a guidance and imaging technique that you can do without exposing people to that. And then I did just put an image on here of a cadaveric slice and then a cartoon showing just how close the lung tissue is actually to skin, and then an ultrasound image of how a trigger point might look. So you've got rhomboid, or you've got trap and then rhomboid, and you can see these layers here, and then a needle coming through. I've zoomed out so that you don't even see the lung in this image, and that's one of the techniques I can do to make myself feel safe about doing it, because as long as I've got my eye on the needle, I know it's not going too deep. So just an example there. Efficacy, so again, we think if accuracy, we hope, portends better clinical outcomes. Many studies show that. Some studies actually show that there's not a whole bunch of clinical outcome difference, even despite accuracy. But many show at least 2 weeks after improvements in pain scores, less procedural pain, as I mentioned, and less recurrence of pain following injections done with guidance. Some of the rheumatologic studies take all comers of rheumatologic disease and look at, what do they report after they get these injections. And one of the studies in particular showed an improvement in range of motion. Yet, even with that improvement in range of motion, they weren't reporting improvement in stiffness and pain long term. And so accuracy may not make clinical outcomes better. I think there's studies that have shown that trigger finger plantar fasciitis, even bursal injections, patients long term don't do that much different. But I would say, even if they're better at 4 and 12 weeks than the non-guided approach, I think that is beneficial to a patient. And the things I would say about that is that safety and accuracy by themselves may justify the usage, and that long-term pain research is always tricky because measuring pain, quantifying pain, no matter what you do, is sometimes a thorny issue, so studies don't always bear out the benefits that we see. Obesity is just an example of something that complicates palpation-guided injections. I think there's a lot of other things like surgical changes that could change your palpation guidance. And then steroids, many of these studies are looking at efficacy after steroid injection, which has systemic effects. So whether you're using a guidance or not, you may have good effects from a steroid. But as we use regenerative techniques, as Dr. Dawson will talk about, biologics, neurotoxins, viscosupplementation, the importance of getting it in the right place matters even more than it does with steroid. One of the so then this is just an example of the needle going into the bursa and the bursa sort of inflating as it's injected, which is a helpful reassurance that you're doing it correctly. So costs, of course, compared to a palpation-guided injection, it's more expensive. But for that reason, some insurers have said, it's experimental and it's investigational, we won't pay. But compared to fluoroscopy, it's less expensive, and it can be performed bedside in an office or clinic, so you're not having to take patients to an ASC or a hospital, which adds cost as well. And then, of course, portability is a big important factor. It's convenient for patients to be seen and be examined with ultrasound as well as clinically, and be able to do the injection at the bedside. Some of our patients in the rehab world are disabled or debilitated or even just in a lot of pain, and so being able to tailor your exam around them and not having them move and be all over the place to try and get an injection done is helpful. So this is a busy, crazy slide. I just wanted to make sure that I listed all of the different things we can do, but essentially, if you have a musculoskeletal tissue that hurts, we can usually inject it and find it accurately with musculoskeletal ultrasound. So I alluded to this, but the different injectates, we don't just inject steroid. A lot of regenerative techniques, viscosupplementation, neurotoxins, and then all the different things that we can do. These are just some examples. This is cadaveric image or slide of the glenohumeral joint, and then the trajectory of the needle, and then a correlate with the ultrasound. So again, just sort of sliding under the labrum into the joint. And then after the injection, we will often do a post-injection examination, which confirms that we have relieved the symptom that we thought we were relieving. Tibio-talar joint, this is again just another example of doing one into the ankle. And you can get people, it's pretty nice to be able to do an injection and someone put their foot down and say, oh, my pain's gone. That's about as diagnostic as it gets. So a hip joint example, just showing the orientation of the patient. We often go to a slightly oblique angle. We can go lateral to the femoral artery. Again, we can find it under ultrasound and avoid it. We can avoid the circumflex artery, and then obviously the femoral nerve. And then the injection itself goes into the head-neck junction. So under the capsule, when you inject, you'll often see this tenting effect of the capsule, and we can avoid hitting the articular cartilage. So this is a nice safe spot to provide the injection. Then the plantar fascia cartoon there, diagram of the anatomy, and then ultrasound correlate. This is actually an injecting into the plantar fascia. That would be like in a PRP injection, we would find some tearing within the plantar fascia and inject the PRP right in the location of the tear. So that's a helpful thing to be able to see. But then also I included this other picture because you can see the plantar fascia is thickened, and that's another advantage. We can suspect that it's the problem, but then when we see it, we see that it's thickened, and it helps us answer that, yeah, that probably is the problem. And this gets a little bit at what Corey's talk. I know I showed like the hydrodissection, but again, one of the things that is helpful is on these squirrely atypical things where you're seeing, you think it's carpal tunnel syndrome. The EMG maybe is normal. A helpful thing for a surgeon sometimes is that we can inject. We obviously are anesthetizing the hand, and they will have a block of the nerve. But if they say, yeah, my symptoms were gone, even if they say their symptoms were gone for 30 minutes, then we know that their hand pain was attributable to the carpal tunnel. Whereas if their hand pain was first joint CMC arthritis, the steroid may help, but they won't have a block in your office. They won't have relief in your office. So it's helpful in distinguishing what a pain generator is. And then I included this slide because we'll see some patients with scrotal pain or pain from hernia, pain post-hernia. And this is just a nice image of what ultrasound can show you. We've got our external and internal oblique, and then this nice little fascial plane where the ilioinguinal nerve rests, and then the transverse abdominis muscle, and then your peritoneum. So you can see all of this come down, inject a little bit right around that nerve, and if not help their pain long term, at least diagnostically say, yes, this is the cause of your right lower quadrant pain or left lower quadrant pain or whatever it is. And just a few other examples, make sure I'm doing okay on time here, but this, I gave a little diagram of the anatomy, but then, so this is quad tendon, patella, and then the suprapatellar bursa. And this point is the needle. This is when you have your probe sort of like this, and your needle's coming into the probe, you'll just see a little point in there, and that's what we would describe as a short axis injection, whereas the one image on the bottom right is a long axis where you're actually seeing the whole length of the needle. But this would be a standard knee joint injection. And there's fluid here, so you can aspirate small volume effusions, which you might not be able to get by palpation. So if you're wondering about pseudogout or something, you can get a little bit of fluid, send it off. But also just, again, to make sure that it's accurate. And with viscosupplementation, as much as Synvisc 1 costs, it's helpful to be able on any patient, but even especially in patients that maybe have, larger body habitus or something, you can be sure that you're in the right place. We did talk a little bit about trigger finger, and this is just a diagram showing the nodule at the A1 pulley. Again, so we can find the tendon here, inject at the level of the nodule. This is a cross-sectional view, so right there is the anatomical correlate, but the artery and nerve run alongside at like roughly the 10 and 2 or 9 and 3 position. You can get a needle right around it without injecting in the tendon, without injecting in any of the artery or nerve that go by, and again provides some diagnostic specificity to your injection. Just a few more examples here. CMC joint radiograph, and then sometimes, this is very close to the skin. It seems like you should be able to get a needle there by palpation. I've found clinically that it's a little painful when you're digging around, bumping into osteophytes. And, with ultrasound, you can avoid that sort of thing, so patients appreciate it. And then the ulnar nerve here, again, just so you're not, we don't routinely do injections for ulnar neuritis. They're not generally very successful, but we have had more success with hydrodissection of the nerve. And again, it helps when you're not sure what the cause of the pain is. So you block the nerve and their pain goes away, then it's not coming from their neck. So in conclusion, we talked about a little bit about what ultrasound does, how it works, maybe a little history of it, and then these benefits, that why we use it, what it's for, how it enhances our practice and improve patient outcomes. But one of the main things that I would mention in closing here is just that as we use more expensive biologic injectates, as we use regenerative medicine, as we use stem cells, neurotoxins, other expensive and highly localized treatments, the image guidance that's real-time that allows us to deliver it effectively and accurately is more and more important. So this is really transforming musculoskeletal, non-operative musculoskeletal care. So, I thank you guys for your time and your attention, and if there's any questions, feel free to fire away.
How many injections would it take you to be comfortable with the anatomy? We've tried this, I've tried this, I think it's very complicated.
Well, in my residency, so one of the well, not like, I wouldn't say a founder, but one of the developers of musculoskeletal ultrasound in the PM&R world at least was at my residency, and we had to document 300 injections with our, to sign off on them for them to say we were competent. And so that's what our residency did. I would say I'm still learning all the time, and it is a very steep curve. Part of the issue is just, the main thing is just that you have an advantage over other people is your anatomy. You've seen these anatomy, in books and images and in surgical. You've looked at the anatomy. So a lot of it then is just the technique of getting used to the probe, how thin the little slice that you actually can see. It's like a credit card's width, and getting used to having your probe lined up with your needle, techniques of just where you orient yourself to the injection. But it is a steep learning curve, and I would say probably 300 sounds about right for me. I don't know, Pete, what do you, Zimba? I think we've done tons and tons, and so it becomes second nature. But I still find myself on patients when I don't get my chair right, I don't line myself up with the screen, with the probe, with me, and I'm trying to just, for convenience sake, reach a little. I still find it to be difficult and technically challenging. And it's definitely not faster. Palpation guidance, I'll still inject a knee without ultrasound because if it's a thin person, it's very easy to get in the joint. I feel very confident doing it. But I find myself still struggling with, if I don't do everything right. But yeah, I do. Let me see if I can back up here. I'll show you the positioning the way I would do the injection. Is it this? No. Sorry about that. Here we go. So this would be the orientation that I would take, and we would inject from the front like this. Yeah, sometimes I'll distract the shoulder a little bit, and we'll open up the space. But honestly, this is a generous glenohumeral joint. Most of the people I'm injecting will have osteophytes and crud or bone on bone. The nice ones are like adhesive capsulitis, where it's a huge space. They don't have any problem. It's just adhesive capsulitis, and it's a nice.
I think when you said someone, are you doing high volume saline?
Yeah, we'll do those. I don't know about, I can't speak exactly for you guys, but I will usually try a couple of steroid injections first, because when it's accurate, and if we'll use about 5 mLs, and a lot of times people do better, but faster. But we'll do the 60 ml injections, and I've done maybe 3 in the last couple of years. It's not terribly common, but great. Thanks, guys.
All right, thanks everyone. I have a 19-year-old, so I stay up for a different reason than Dr. Gertken. And I also have this horrific ragweed allergy, and I'm really doped up on antihistamine. So my voice is not normally this scratchy. So if I have to stop and take a drink, it's because I coughed all night. This is a generic shoulder talk, but I want to make sure that we have an open forum to discuss whatever. I mean, we have different disciplines here. We have different approaches to the shoulder. We have athletic trainers. I see physical therapists. I see primary care doctors. And so I think we have a lot of opportunity to get some questions answered. But I really want to hit on the topics that I see the most in my clinic that I think we could do a better job at taking care of the shoulder. Disclosures. So we're just going to go through some anatomy, which I love. I think if you understand anatomy, you can understand the exam, you can understand the treatment, you can understand the rehab. I think all of this starts with anatomy. Imaging, I think we have an opportunity to clean up our imaging. I think we're all guilty of ordering tests before we put our hands on patients. I think that's a mistake. It's not always practical to do that, but there's some ways that I think we can all do better. I'm going to ask someone to volunteer, or actually force them since she works with me, to do an exam. And I got a couple cool movies that I think illustrate anatomy, and I've got a slap tear, a labral tear that we did a couple weeks ago that's pretty interesting. And then we'll leave the back side of this for open discussion. So we all know this, we're all smart people in here, so we'll skip this easy stuff. But one thing about the shoulder that makes it hard to image is that it's capable of something called circumduction, which means it can be in any infinite number of positions. So when we look at a knee and we put it in an MRI, it can only flex and extend, so the structures aren't as dynamic during the MRI. So I palpate bumps a lot in clinic, and I think you have to know these three bumps of the shoulder: the clavicle, the acromion, and the coracoid. The coracoid's the bump in the front of the shoulder. That gives you sort of a key slot to find the glenohumeral joint and the subacromial space. These three ligaments and this tendon have a lot to do with athlete shoulders, a lot of confusion about these ligaments and these structures. So the biceps tendon is sort of the bane of any shoulder surgeon's existence, and actually I'm sure Pete would say it's such a hard pathology to understand and treat and diagnose. It's probably the #1 pain generator in the shoulder for a number of different reasons. It's a very long interarticular segment. It sort of just hangs out there in the breeze. These three ligaments that we see in surgery, and I've got a surgical video that will show better: the superior glenohumeral ligament, the middle, and the inferior glenohumeral ligament. In my experience, #3, the inferior glenohumeral ligament, is really the key to instability in an athlete's shoulder who's dislocated. And everyone talks about the labrum, Bankart tears. We've all heard that term, but I really think that this inferior glenohumeral ligament, getting it properly tensioned and positioned in surgery, is the key to successful outcomes. So here's those ligaments looking from the lateral view. Superior glenohumeral ligament can sometimes just be a wisp of capsule. I don't pay a lot of attention to that. The middle glenohumeral ligament's important because there's a lot of variability in the anatomy of that arthroscopically. And if you tension a middle glenohumeral ligament and mistake it for a labral tear, you can really crank down someone's shoulder, make them worse instead of better. And then the inferior glenohumeral ligament is a very broad ligament, and the anterior band is something I'll show you that's the most important. So we all know the muscles of the rotator cuff. I think the rotator cuff and shoulder anatomy is very complicated, very confusing. It wasn't until I sort of figured out shoulder arthroscopy that I truly understood it. So we all hear our patients come in and talk about their rotary cups. Well, the first tendon of the rotary cup that everybody knows about is the supraspinatus. The supraspinatus comes across the top of the humeral head and attaches to the greater tuberosity. The biceps tendon runs just anterior to that in the interval between the subscapularis and the supraspinatus. So here you can see that biceps tendon coming between the subscapularis and the supraspinatus. And then the two tendons in the back, the infraspinatus and teres minor. And I tell people that when they come in, they say, well, my doc said my supraspinatus or my infraspinatus is torn. I can tell you in surgery, I'm not good enough to see the differentiation. The rotator cuff truly is a continuous cuff. So let's try to make this work here. So this is a 16-year-old girl with 3 years of shoulder pain, overhead volleyball athlete, club volleyball player, several rounds of physical therapy, negative MRI, questionable MRI arthrogram, parents come back. We all know these patients. So we end up in the OR. I don't typically scope 16-year-old negative shoulders. So you see how the cuff just is one continuous structure. You can't like see where they stop. And we have to find something for these poor parents and their daughter with shoulder pain. So we saw a little fraying of the labrum, but that's not enough to... Oops, hold on. So here is now the camera's in the front of a right shoulder looking to the back. So that's not entirely true. There is a posterior inferior glenohumeral ligament, but unless you have isolated single direction instability, it's really not significant. But you can see how in the back of the shoulder the capsule is very wispy and thin. In the front of the shoulder it's actually quite stout. So we'll do a little bit of imaging here. And I say we almost always get 3 views of the shoulder to include an axillary. The axillary gives a great view of the glenoid bone stock. It actually will show us if there's some early arthritis as opposed to just a simple internal and external rotation, which we sometimes see from the basic x-rays from the hospitals. We almost always get x-rays before MRIs. Now I have great relationships with most athletic trainers. Sure, if you guys call me, dislocated the shoulder or felt a pop, of course we're going to get an MRI. We'll go straight to it. But in general, we like to get x-rays before MRIs. And then this may change for me, but I tend to order almost all MRI arthrograms in suspected cases of instability and or labral tears. That might change, but we'll talk about that in a bit. And then I say we almost never order MRIs before x-rays, order MRIs before we get to put a hand on patient. And then this happens once a week. We order MRIs on super old people who come to my clinic and say, no way in hell I'm having surgery. And I'll show you one that I actually have an example of that. So this is a super old person's MRI who come to me and said, I don't know why I'm here. I'm not having surgery. So what you can see here is, all right, I'll do my best here with the pointer. The black is muscle, the white is fat. And if we look at the subacromial space here, there really is none. The humeral head is almost articulating with the acromion. And so the supraspinatus is just a wisp of muscle. Really, there's no muscle. And here is the edge of the rotator cuff, right here at the magnifying glass. That edge belongs right there. So no surgeon in the world can get that tendon back to that part of the greater tuberosity. So this is $1,000 that was just wasted. I mean, medicine's an in-sum game, $3.5 trillion. And if we continue to waste money doing stuff like this, we're all going to take a pay cut. It's just the reality of it. So in a perfect world, we get to see every shoulder pain that comes in traumatically, and we would get to order the after imaging, but it's not a perfect world. So if we talk through some of these, then we can get the right imaging study. So we suggest that we order standard x-rays, and I'll give you all my cell phone number. Many do. I don't mind a call. Hey, Brett, I got this. What test should we get? Well, let's talk about it and get them the right test. We're working harder and harder and harder to get your patients in the same week because we want to provide that level of service to the patient and to you guys. So if you don't want to pick up the phone, send them. We have a walk-in clinic now, and we usually will add patients on if you ask us. So let's go through some of these complex decision trees when we talk about imaging. So, 17-year-old senior football player felt his shoulder slide out when he put his hand down after being tackled 6 weeks ago. He's still playing, he's having pain. So I would like to know what you guys think. What would you order? Now we're going to assume all plain x-rays have been ordered, so you don't get that one. Anyone want to take a stab? I mean, there's no right or wrong answer. This can be a discussion. We're not going to call you out and call you stupid, but I'll tell you what, I'll go first. This is one that I would order an MRI arthrogram. this sliding out is probably real. He's probably subluxing. He's probably moving around. He probably has some instability. And an MRI arthrogram is going to be the best test, in my opinion, to look at his labrum and his ligamentous complex. So this is different than a 16-year-old who threw her hands up to grab a rebound and dislocated her shoulder, requiring a reduction in the ER last night. There you go. So last night, that's the key. I think in this case, a standard MRI would probably give us enough information, because when you have a traumatic shoulder injury or dislocation, you get a free arthrogram, right? You're going to bleed into the joint. So you're going to have a hemarthrosis. So a quick MRI, that's why if this happens on a Thursday or Friday, I want the MRI the next day, because I get a free arthrogram without having to stick a needle in that kid. So that one I would order a regular MRI on. A 30-year-old who fell skiing last year and landed on her elbow. No one wants to play the game, huh? I'd order an MRI arthrogram on that patient, because I'm very suspicious if they land on their elbow for a superior labral tear, a slap tear.
What's a year old?
30.
No, I meant last year it happened, a year ago.
On what? On 30-year-old?
Has she not seen anything before that?
Oh, no. No, this is someone who presents to my office and says, I fell skiing last year, I continue to have shoulder pain, and we've had the regular PT. So now we have someone in my age group who fell on the ice last winter and landed on their outstretched arm. Again, they've had PT x-rays. So I'm suspicious for cuff in this person. I would probably just do a standard MRI. I put these to illustrate that it's a complicated decision tree. It's not a knee-jerk MRI arthrogram. There's a lot of experience that goes into figuring out which test is best for the patient. So switching gears, here's a 30-year-old weightlifter who has bilateral slap tears. And we did his other side about 8 weeks ago, got him out of his sling so that we can make sure he could take care of himself. And then we did this side last week, or 10 days ago or so. Oh, poop. Media not found. Okay, well, that's all right. We got more to talk about. So this is something that I'm excited about. This is actually I'm going to be able to have one of these next Friday. I know Dr. Mike Smith has got to put his hands on this at the headquarters in Naples, but this company come out with something called a nanoscope, which is going to be a tool we can use in the office to quickly diagnose and do some treatments for knee and shoulder injuries, but they're actually putting these scopes everywhere. Blake sent me a picture from Instagram of one of his residency buddies that put one in a spine already. I mean, this is going to be a very small scope with very high quality video and these micro instruments that we are going to be able to do under local in the clinic, and patients can watch with you, and it's here actually. Where I'm excited for many reasons. Number one, there's all kinds of scenarios when this is going to be useful. We've all seen, I see lots of rehab people in here, we've all seen patients who fell 3 months after their rotator cuff, and we don't know. Should we keep rehabbing? Should we rescope? Did it re-tear? Because imaging is inconsistent with finding out the right answer. So we can numb them up, stick the scope in. Yep, your repair is good. Get back to rehab. So this is actually pretty exciting stuff that is, I think it's going to be the direction that arthroscopy is going to go in the future. So let's go through a physical exam. Alice, come on up, please. I'm going to take this off. I got to move. Oh, fancy. Yeah, okay. So I'm going to give you my standard shoulder exam. This is going to be the comprehensive. This is going to be my 2 minute, 1 minute exam. We're behind 30 minutes. Now we have to give the patients their value and give them a full exam. So the first thing I do, obviously inspection, but if it's an athlete, we come over here, Alice. We put our palms up, elbows in, and we push against the wall. That's a good way to look for scapular winging. So I learned that test at a conference, but pushing that will activate the serratus, and they will really show their winging. So then stand here, Alice. So the next thing I do, face me, is I have elbow straight, thumbs up, and I just check for range of motion to the front and to the side. And so here's a valid point. So the plane of the scapula is really about 45 degrees. Abduction shouldn't be done here. Abduction should be done about 45 degrees in the plane of the scapula. So I do abduction here. And then we have our elbows at our side, swing out. And then we put our hands on our back. So this is checking internal rotation. The lift-off test, which I think is hard with my old shoulders, is a test of the subscapularis. My favorite test for the subscapularis is the belly press. So I have patients say, push your belly button in. I support their elbow. That's a great test for the subscapularis. And then almost everyone gets a speeds test, which is palms up. We push up to the ceiling, and I put my hand in the bicipital groove, keep the elbow straight, push up. And then the best test, face the audience here, for a superior labral tear is an O'Brien's test. It's about 30 degrees of adduction, thumb down, gentle push up to the ceiling. If they pee their pants during that test, they usually have some sort of a labral tear. If we're looking for instability, there's all kinds of specialized tests, abduction, external rotation, apprehension tests, but those are specialized. You can sit down. But if you can do that quick 1-minute exam, you're going to cover most shoulder pathology. I had a funny patient this week. She was kind of crazy. She was a lot crazy. Whenever you go in the room, you're like, hi, I'm Dr. Miller, and they go like this. You know, it's like that, or if they have a high pain tolerance, you're like, oh man, they're crazy. So I'm like, okay, right shoulder, yeah, right shoulder. So do what I do. She goes like this. I'm like, what's wrong with your left shoulder? Nothing. I mean, these. Well, I got another great story. I had this guy did her ACL. You heard this story with the put your head on the bed. So I did her ACL, and her mom wasn't with her. She was just coming for a post-op check, and we have an exam bench there. And I always go up and I say, just put your head right here on the table so that they'll lay down. So she goes over and she goes like this. Patients are great. Anyway. So that middle glenohumeral ligament is actually very stout. There's some variations of that anatomy. And before we knew a lot about the intra-articular anatomy of the shoulder, after tens of thousands of arthroscopy, people would think that was a pathologic lesion, and they would repair that to the glenoid, and then patient's external rotation ended up being this. So there's a lot that goes into stabilizing these shoulders. Not everyone needs to be socked in. Not everyone needs everything repaired all the time. Matter of fact, in someone my age, if I had this slap tear, I don't typically put much, if anything, anterior to the biceps because I think they lose this rotation, struggle with it immensely. And I'll just tell you my cutoff for repairing a superior labrum is in the mid-50s. I did repair one the other day in a late 50s guy who was a construction worker, very fit-looking person, and I'll tell you, they tend to struggle with their motion, and I know you guys have all rehabbed these patients. So it's a very delicate balance trying to take care of those folks, and it's why we all need to communicate, because we have different expectations for all these patients. So I'll leave the floor open to questions now, if you have any. None? All right.
So it's good to have Dr. Miller give us that intro to the shoulder and the anatomy review. That'll be helpful going forward here. My talk is going to be more about what to do with the old guy with the MRI that he doesn't want to take care of. So just an overview of the presentation here, some things I hope you take away from it. I'll talk a little bit about epidemiology, who shoulder arthritis affects, how these patients are going to present to your care, what kind of x-rays or MRI or CT scans are appropriate to order, treatment options for arthritis of the shoulder, with a special focus on anatomic versus reverse total shoulder, some kind of recent shoulder surgery outcomes papers, and then some complications that may be present around the time of shoulder surgery. So epidemiology. This is a big population that we take care of. So up to 20% of the population over 65 is affected. And a paper in 2015 highlighted the fact that the demand for shoulder arthroplasty procedures is going to go up significantly in the next couple decades. So over the period of 2011 to 2030, in the group of patients over age 55, it's expected to increase by 755%. So that's going to be a huge demand, a huge burden on the system. Shoulder arthritis presents in a couple different ways. The 6 kind of major groups that you can get lumped into are primary arthritis, secondary or post-traumatic arthritis, rheumatoid arthritis, rotator cuff tear arthropathy, capsulometry arthropathy, and avascular necrosis. I've kind of highlighted the 2 most common that we'll kind of emphasize a little bit more during the talk. These each have some characteristic radiographic findings that can help determine the appropriate pathway for the workup and especially for treatment options for these patients. So these individuals are going to present to us with chronic pain, acute flares, pain at night, interrupted sleep is a very common complaint. Decreased range of motion is usually a hallmark of arthritis. And people typically talk about how they can't get their hand above their head, behind their back, can't shampoo their hair anymore, inability to lift heavy objects, to throw. And many of these people will have a prior injury history, sometimes prior surgical history. So Dr. Miller did a good exam demonstration. Some things more specific to arthritis. Again, looking at range of motion, looking at atrophy or previous surgical scars. I've put down some rough numbers for normal elevation. So if your patient presents with significantly less range of motion in forward elevation, abduction, or external rotation, it should certainly have you thinking about arthritis as a possible diagnosis. Testing strength is really important for arthritis because we'll get into this. The presence or absence of rotator cuff tear is going to be a big factor in determining what the best treatment option is for these people. Impingement tests can always be used. And Sperling's test, I'd be remiss to not include this because this is something my mentor in residency was always adamant about including. This is a test for cervical nerve root compression. In the shoulder, you so commonly have different patterns of pain being referred from the neck, from the back. So Sperling's test is kind of a quick and easy way you can check and rule that out, rule it in. It may take your diagnostic pathway down a different path. So like I was alluding to, this 65-year-old male with shoulder pain is going to have a big differential diagnosis. And it's important to kind of sort out intra-articular shoulder pathologies versus extra-articular. Glenohumeral arthritis being kind of the topic of this discussion, but you can also have focal chondral lesions that aren't always as obvious on the x-rays. You can have soft tissue problems like labral tears, instability, biceps tendinitis, and the extra-articular pathology like impingement, bursitis, rotator cuff pathology, and again, cervical nerve root problems. So starting the workup, key for arthritis is x-rays. And I narrow it down to just 2 x-rays that I find most useful in establishing a treatment plan for these patients. The true AP view, the Gracie view, and the axillary view. And these are our orthogonal x-rays, 90 degrees from each other, gives us a good picture of how the shoulder is functioning. 3-dimensional imaging also plays a huge role in what we do, kind of depending on how the patient presents. If they have a little weakness and we're worried about whether the rotator cuff is working adequately, if there's a small tear that can be repaired or not. but also to categorize the deformity that's present around arthritis. Because I'm going to show you some pictures here of how bad this can be. There's one on this slide here that shows, maybe I can use the mouse, the degree of deformity on the back side of the glenoid, or the socket side of the shoulder. So this has a bearing on what our options are for arthroplasty. So this is that true AP view. And again, Dr. Miller alluded to the fact that the scapula is not in a perfect coronal plane. It's 45 degrees off from your coronal plane of your body. So in order to get this AP view, you have to tilt the beam. And the goal is to look right down the glenohumeral joint. And this is a picture showing an arthritic shoulder with some osteophytes. The axillary view, 90 degrees from that, but looking up from the armpit. You're looking up, trying to get a 90-degree view of the shoulder here. And again, this is showing a lot of arthritis, joint space narrowing. So I alluded to the fact that there's some characteristic findings on our x-rays with these people that are affected by arthritis. So in our group of primary osteoarthritis patients, you have flattening of the humeral head and enlargement of the humeral head, and this goat beard osteophyte that I've outlined there, which I think is a good description for that. That's kind of your telltale sign of this primary arthritis. The glenoid tends to wear out on the back side. This is the posterior aspect of the shoulder. And in these folks, in general, rotator cuff tears are rare, fortunately, and that helps us with our treatment options. Secondary OA or post-traumatic arthritis can lead to a lot of deformities. So these are people who may have had a fracture that was treated conservatively, or with surgery. You might find hardware, screws poking through where they shouldn't be. These patients, I always worry, at least have the presence of mind to think about the possibility of infection if they've been operated on before, because infection can lead to significant deformity as well. Rheumatoid arthritis folks have a different pattern, very often characterized by destruction of the joint, and they have more of a central wear pattern. They won't have that goat's beard osteophyte typically. And here, rotator cuff tear arthropathy, this is the other big group. This is the patient, the super old guy with the MRI. The big characteristic finding here is that after a period of time, 10, 15 years, without a rotator cuff, you lose the dynamic stabilization of your ball in your socket joint, and you tend to ride superiorly. So you can see on this picture, this is a pretty advanced case, but it's gone so high that it's actually started to articulate with the undersurface of the acromion here, and that's called acetabularization. But this tells us in a single picture that this individual doesn't have a rotator cuff tear and they've got bad arthritis. And that helps us lead down the pathway to the appropriate arthroplasty option for them. I think this figure is helpful. This is the Hamada classification, but it depicts in a couple of slides here the changes that occur over time, where you have that narrowing of the humerus to acromion distance. It leads to the eventual deformity, the acetabularization there. AVN is one more with very obvious deformity changes on this case, but sometimes it can be subtle. Sometimes it can be just a little crescent of sclerotic bone, and an MRI might be more appropriate to diagnose that. Some cases, when we have our 65-year-old male with shoulder pain that wakes him up at night, his x-rays aren't as bad as it would suggest based on his description. We can use injections. Our partners at PM&R, my partners in the clinic, we can use these injections in the subacromial space, in the joint space, cervical epidural injections. All these can help rule in or rule out pathologies. So if you get relief with a glenohumeral injection, you've pretty well narrowed down that that's the patient's problem, and we can proceed forward. MRI, again, if the x-rays are equivocal, MRI can help characterize a focal defect. It can help show off those soft tissue pathologies. We also will consider getting a CT scan to help better characterize that deformity that I was talking about before. So if you look at, on this page, A1 is kind of a typical glenoid pattern. Most patients that come in with bad arthritis will be in the B2 category, where they start wearing out on the back. So a CT scan will help show that to us. When we talk about treatment for these patients with arthritis, keys to success, just to summarize, identify the underlying pathologic process. Define that deformity, the anatomic challenges that are going to determine what implants we use, what approach we take. Help the patient to understand what the disease process is and what our goals of care are. So this is kind of an overview of our management options. Of course, we try to start with non-operative treatment options. NSAIDs, analgesics play a role. Physical therapy is important to work on scapular stabilizers, strengthening, improving range of motion around the shoulder. And then we can also do injections for therapeutic purposes. So cortisone is a mainstay. I included Zilretta on this slide because it's in the pipeline. It's actually a long-acting cortisone formulation that's been proven in the knee. It's in clinical trials in the shoulder. And it may be an option for us before long with FDA clearance. From an operative standpoint, 6 different options on the slide here kind of cover the whole gamut from minimally invasive arthroscopic surgery all the way to resection arthroplasty where the shoulder joint is removed. Usually the sweet spot here in the middle between a total shoulder reverse is where most patients will land. But I'll cover kind of each of those in turn. With physical therapy, important guidelines to work with gentle range of motion and strengthening. Vigorous torque around the shoulder in an arthritic joint can exacerbate the problem. When you start to lose the congruity of the joint, when you apply torque to it, it tends to translate rather than stay central within the joint. So extra torque can force that translation and cause some shearing and exacerbated pain. The steroid injections I mentioned, ideally no more often than every 6 months or so, but they do tend to have diminishing returns over time for patients. Arthroscopic debridement is used in limited cases, I'd say. This is individuals under 60, maybe under 50 that have early signs of arthritis. If we have advanced stage 4 arthritis based on the x-rays, this isn't going to be very helpful. But in some cases, it can be helpful to clean up torn pieces of labrum, cartilage that might be getting caught, some loose bodies that can be removed, address any biceps pathology that might be lurking in there. But all in all, it's a less invasive approach. It might buy some people some time. It does have good outcomes in the right patients. So if you're looking back to 2000, there are several studies on this slide. I think what it boils down to here is the summary of the 2010 article. The big risk factors that have been identified for failure of this approach are grade 4 bipolar disease, meaning involving the humeral head and the glenoid, joint space less than 2 millimeters on the x-ray, and large osteophytes present. So those people are exempt from an arthroscopic approach. You can also consider hemiarthroplasty, which is a procedure for primary arthritis that is kind of a bone conserving approach. It has some pluses and minuses. On one hand, in a young patient who you're worried that might need a future surgery, you can preserve as much of the humeral head as possible. So you can use something like a resurfacing here that doesn't remove a large amount of bone. It can also be for patients with that are older, that have preserved motion, or if they have AVN. Its advantages are that it's a shorter procedure, less technically demanding, lower instability risk. It can be converted at a later date. But its disadvantage is that when you don't replace the glenoid side, you have a metal on bone articulation that can tend to wear that out. Less reliable pain relief has been shown in the literature as well. So we can go past this to total shoulders. I think total shoulders are kind of the bread and butter here. This is going to be the primary treatment option for people that have primary arthritis and an intact rotator cuff. Replacing both the ball and socket of the joint. We have to have sufficient bone to do all this. So some people who have significant deformities might not be candidates for this. And you have to have, again, intact rotator cuff and intact deltoid in order to move the shoulder and protect the joint replacement. The glenoid component is a piece of polyethylene that gets cemented into the scapula. And it does come with consistent pain relief for patients and improved active motion. Historically, there's been concern about this glenoid component loosening, but the modern implants have addressed that with some of these ingrowth materials that help to keep things fixed for longer term implantation. They've been shown to have great outcomes in the literature. There's a couple of just more recent papers of 320 patients and 42 patients here showing good survival over time, good improvement in these functional scores, the American Shoulder and Elbow Society scores at follow-up after total shoulder replacement. If you compare these options that I've listed so far, total versus arthroscopic debridement versus a hemiarthroplasty, in young people under 60, it shows that pain scores, this is a big systematic review, so 1,200 patients, but pain scores are significantly better after total shoulder. Range of motion is improved with arthroscopic debridement and total shoulder. Satisfaction scores are similar for hemiarthroplasty and total shoulder. Complication rates less common with the debridement, which makes sense because it's less invasive, but revision rates are equal across all groups. So this is a way we can counsel patients about kind of the best path to take when we consider those options. For the reverse, I brought up this picture again showing that high riding humeral head, the cuff is deficient or torn. When that happens, historically, when total shoulders were done on these patients, that glenoid piece would fail because the humerus tends to want to climb out of the joint and it places this translating force on the glenoid. So some French surgeons in the 80s figured out how to reverse the architecture of the shoulder. This has been an implant that has been FDA approved since 2004 in the States, but it's been used by the French since the 80s. And I think it's really remarkable the way they came up with this idea. It changes the leverage. I think I can show in the next slide. It changes the leverage. Since you don't have a rotator cuff any longer, you use your deltoid functionally as your elevator and abductor for your arm. It does that by medializing the center of rotation, changing the fulcrum on how you're going to raise your arm, which enhances the torque and overall restores that muscle tension. These are what the implants look like. Now, when this first was cleared for FDA approval, it had a very narrow indication. You had to be over 72, you had to have rotator cuff tear arthropathy. But now the indications are expanding. And that mostly has to do with us kind of as a specialty getting out of this learning curve phase. And I'm going to show you, there's some early studies that didn't show great outcomes for this. I think we've kind of fine-tuned the appropriate approach and implants and everything that give us confidence to expand these indications for using it for its original indication, but also for fracture purposes, for failed total shoulders as a revision option, for folks that have bone loss or a deformity that's too significant for a total shoulder replacement, and in cases of infection where you have to remove a large amount of bone to kind of stay ahead of the infection. It does come with contraindications though, highlighted in red here. Obviously, if the deltoid's not working due to a nerve injury or some sort of paralysis, brachial plexus problem, you're not going to be able to restore that lever arm using a reverse either. Other things have to do with having the adequate bone stock for the implant. This criteria is a lot easier to satisfy with a reverse than with a total. So early outcomes, like I was mentioning, in 2005, this is just a year after it was approved, FDA clearance for the United States, they're showing a pretty high failure rate, 17% failure rate out of 60 patients, 39% complication rate out of 58 patients. Here in 200 patients in 2007, there's a 7.5% dislocation rate, high infection rate, problems with revisions, post-traumatic complications. One more here. This is now 2011 with some probably on the downslope of that, that kind of learning curve, where survivorship to revision is almost 90% at 10 years. Constant score, which is a score that measures shoulder function, is improved. And radiographic deterioration was one thing that people continue to keep their eyes on, but not necessarily related to clinical outcomes. The more recent papers here are definitely encouraging. So this is 2017 and 2019. I especially draw your attention to this one. So this is 1,650 patients with primary reverses implanted over 6 years by fellowship-trained surgeons with a very low reoperation rate of 2.4%. And that area where I was talking about this radiographic problem is down to 0.4%. So we're trending in the right direction for this surgery. And I think it's a really useful tool for the old person without a rotator cuff. So we all understand some perioperative management pearls here. These patients typically get a nerve block, sometimes an indwelling nerve catheter around the time of surgery. They're admitted for usually 24 hours, sometimes 48 hours, although outpatient total shoulders are becoming more popular. We do have some restrictions about Medicare letting us do that, so that's primarily for the commercial insurance. These patients are put into a sling for 6 weeks for everything to heal. Physical therapy, though, begins immediately, where under physical therapy guidance, we want to start working on some passive range of motion in a way that protects the surgery and the repair, particularly of the subscapularis that's going to be strained with too much external rotation. And these patients follow some of the general guidelines that we use for all arthroplasty procedures as far as DVT prophylaxis, using aspirin for low-risk patients and Eliquis or something similar for the higher-risk patients. Some complications listed here, things that we like to be aware of, like to monitor these patients for long-term, problems with loosening of the glenoid, failure of our repair. It's kind of an early problem that we want to avoid, which is why we place the restrictions on these patients post-operatively. Sometimes stiffness is a problem, infection less so. Nerve injury, because of the place we have to be to perform the surgery, can happen, but luckily it's rare. Instability, HO, less common. This just to show our infection rate. This is, interestingly, these are very low reported infection rates and trending in the right direction. For shoulder arthroplasty, it's a little bit higher than total knees and total hips, but there's been a lot of concern about the bacteria that tend to live around your shoulder, the P. acnes and everything, that might be contributing to a slightly higher infection rate around shoulders. And DVTs do happen, even though these people aren't immobilized, they are still at risk. So that's why I mentioned the DVT prophylaxis. So to wrap it up, this glenohumeral arthritis does comprise a wide variety of complex problems. We have some characteristic radiographic findings that help us identify which patients would benefit most from certain treatment options. Understanding the anatomy and biomechanics helps with that, determining anatomic, total shoulder versus reverse. And we continue to have these solutions emerging that we're incorporating into our practice from this evidence-based approach. Further experience now with these newer techniques can only be expected to improve outcomes from what we're seeing. And there's my little guys. A 2.5-year-old and 6-month-old twins at home. So we're busy. I'd be happy to take any questions, though, about shoulder arthritis, shoulders in general, if you've got any. Yeah.
So in the past, the only frustration with reverses are that the patients are never told expectations with internal rotation. And so they'll say, why can't I get my wallet up? So what will you tell your patient? What do you expect?
Yeah. So I think that historically it's been a bigger problem than it is with the more modern implants. They've actually, I showed you the first generation of how they medialized the center of rotation and distalized it. With some of these inset prosthetics, that's less of a problem. I do think it's worth the patient's understanding that the range of motion will be different. Really what we tell patients, and these are patients who come in with arthritis that can't get their shoulder up to 90 degrees. So we tell them that we should be satisfied if you can get your hand above 90 degrees and touch the back of your head, but reaching around and you know, putting your belt through your belt loop might not be in our goals.
Can you demonstrate this Sperling test?
Oh yeah, so the Sperling test, you have to actually put compression on your patient. You know, sitting in a chair, you have them turn their head towards their shoulder, kind of tilt towards your ear to your shoulder, and you put pressure on their head, kind of compressing the cervical spine. So if there's irritable nerve roots, that'll send a shock down their arm. That's a positive Sperling's test.
How hard are you motioning?
Not hard. Very often, people just getting into that position will notice a little spark down their arm. So that would also be a positive. But sometimes a little extra compression can elucidate that. Yeah.
What are you doing again for DVT prevention after arthroplasty?
So primarily following the joints protocol. So aspirin, 81 milligrams twice a day for 30 days. Eliquis for folks with higher risk factors. All right. Well, thank you guys.
All right, very good. So we're going to kind of, thank you for that. We're going to go over some of the current concepts in hip and knee replacement, how that field has changed dramatically in the past decade, and then also talk about when you have patients in your clinics, for the primary care folks here, what kind of things we can do to try to prolong the need for joint replacement and make sure we're taking care of them appropriately. So like I said, review arthritis and joint replacement, go over some treatment alternatives, talk about the surgical concepts and rapid recovery, and be sure we give some time for questions. These are my disclosures. Arthritis, as we all know, is an incredibly common problem. 81 million Americans are affected by hip and knee arthritis. The lifetime risk of developing symptomatic knee arthritis is about 45%. So at some point in your life, you're very likely to have some sort of knee pain. As you can see by that graph, it's obviously an age-related problem, birthday-related problem, as I like to say. Arthritis, all types of different types of arthritis. You know, you hear about people talking about rheumatoid arthritis or inflammatory arthritis, psoriatic arthritis. The one that I'm going to focus on today is primarily osteoarthritis, which is either from a primary cause, which is usually a genetic issue that you can blame your parents for. The other often common causes are post-traumatic arthritis, which is secondary to some sort of injury, whether it be a car accident or just a minor trauma like a meniscus tear that can lead to arthritis down the road as well. Osteoarthritis is wear and tear. So this is miles wearing the tread off the tires. This can be very multifactorial, like I talked about. Having abnormal alignment of your limb, having trauma, having overuse, or most likely the vast majority of people who develop arthritis have some sort of genetic component that we don't quite understand completely yet. But if your parents have had a joint replacement, the odds that you will have a joint replacement are higher than someone, your friend, who doesn't have a parent who has a joint replacement. This is an analogy I use in the clinic a lot. The knee in particular is a lot like a hinge on a door. A nice healthy joint is one that is moving very cleanly. It's well lubricated. You have full motion and it doesn't squeak and creak when you bend it. The arthritic joint is a lot like a rusty hinge. It starts to get all these growths on it like bone spurs. The joint becomes very stiff. It loses that lubricated feel to it and it becomes painful. And it does also make the same kind of noise sometimes. Diagnosis, the number one kind of step with getting a good diagnosis is talking to the patient about their symptoms, their history. How did you get to where you are? How long have these symptoms been going on? I start to perk up more when people tell me this has been a year, 2, 3, 4 years. When someone says it's been 2 or 3 days, it's less likely to be, you know, an arthritic thing. It's more likely to be just an acute injury of sorts or a flare-up. Physical exam is a huge part of this. I look at how much does this joint bend, compare it to the contralateral side. You know, if someone hopefully doesn't have bilateral disease, at least you normally have a nice normal exam on the other side that you can compare to. And then seeing and documenting what particular maneuvers cause that pain, and is it reproducible on exam? And then x-rays. I want to spend a little bit of time here talking about what x-rays look like and how we get them and what are important things to be both ordering and looking for when you have x-rays. So the absolute most important part about getting arthritic x-rays is getting weight-bearing films. So, and that's, for the primary care providers here in the audience, you have to sometimes, usually, notate that in your order that you want weight-bearing films. When you take supine x-rays, the effect of gravity is not seen, and the effect of gravity is dramatic. You can have very normal-looking joints, and then I'll look at the x-rays and go, that looks worse than it really is, and we'll go for weight-bearing films in our office, and they have bone-on-bone arthritis, and you don't see the deformity that is caused there. This is what a normal hip looks like, though. Nice, round, smooth ball, nice, round socket, space between the two. No bone spurs. But comparing that with an arthritic hip, you see not only is this patient worn the tread off the tires, but they're also wearing the rims flat here. So the top of the femoral head is flattened off. There's huge cysts in the bone called subchondral cysts, and the bone is white. It becomes hardened over wear called sclerosis. So that's obviously a deformed, painful hip. Normal knee, in this x-ray here, nice smooth surfaces. There's no growth looking things like bone spurs on there. There's space between the bones. Comparing that with an arthritic hip again, or arthritic knee, you start to flatten off that femoral condyle. The space is now gone. You see the bone is whiter as it gets more sclerotic and bone spurs are forming. You can see also the varus deformity of this knee, how a little bit bow-legged, kind of looking like John Wayne when they walk in as they start to get that varus thrust as they walk around. So what about MRI? Where does MRI fall in this whole spectrum of care? Usually not needed. Patients over 60, the chance that they need a hip or knee MRI is really, really, really low. Weight-bearing x-rays are the very best thing for us to see. We use, as surgeons, MRIs as pre-surgical planning tools, so whether or not we'll, in the shoulder, like Dr. Smith and Dr. Miller talked about, how those are pre-surgical planning tools, those are helpful. In the hip or knee, it often just leads to longer conversations that you and I are having to talk with them about how we're not going to repair their meniscus in the 85-year-old person with occasional knee pain. So it's okay to order them in young folks, but older folks just really not going to help you not going to change your decision a lot. Arthritis, the treatment of it is predicated upon how the patient is feeling, not what their x-rays look like. I have this conversation every day about how I treat people, not x-rays. I have some people with awful, terrible looking x-rays that are living very functional, happy lives that I just pat on the back and say, let me know when you don't. And then people who have a little bit less mild disease that require a little more hand-holding and kind of figuring out what to do with and how to get them to feel better. Patient education is the number one way to kind of get this process going for them. Talking to people, having them understand their problem will oftentimes lead to more productive discussions down the road. Weight reduction. The knee joint, for example, experiences up to 6.5 times your body weight in force. So I always have this conversation. You lose 10 pounds, you're looking at 40 to 60 PSI coming off your knee joint. That's the pressure in your car tires coming off your knee joint, and it will make them feel substantially better. And if they go on to have surgical treatment, this will make surgical treatment that much easier and that much safer for them. We do think the joints will wear out slower, so there's always this discussion about, oh, should I be running or should I be walking? Am I putting more miles on it? And we've actually have more and more data coming out of the running literature and sports medicine literature that says that long distance runners are actually less likely to have knee arthritis than their counterparts who are not active. So it's not the miles you're putting on the tire, it's the force you're putting through it. And then, like I talked about, safer surgery. As far as a surgical cutoff, we don't have a hard cutoff. We have a goal of a BMI of 40. Anything less than 40, your risk is very similar to a patient who's a normal body weight. Over 40, we start to look at patients on an individual basis. As you all know, you've seen people with a BMI of 42 that are shaped in very different ways. There's the muscular male who's all upper body, has the skinny little railed knees that probably doesn't have the same risks as the person who has larger lower extremities, is also diabetic and smokes. And you have to start thinking about the patient in general. But our typical goal when we talk to patients is trying to get them as close to or under 40 if possible. Activity modifications. Low impact exercises are excellent for arthritis. Aquatherapy is wonderful for arthritis. It decreases the symptoms, it reduces their body weight, it keeps their muscles moving like they should, and also not only reduces their symptoms, but does make their surgery more successful if they get to that point. Anti-inflammatories, all kinds of anti-inflammatories from topical to oral anti-inflammatories. There's not one that's better than the other. We like to use a lot of COX-2 inhibitors like Celebrex if we're talking about surgery because those are safe to take to and through surgery and don't have to be stopped. They don't have as much bleeding risk as some of the non-specific NSAIDs. But whatever, if they are a good medical candidate to be taking these, then I think they are an excellent choice. The one thing that you will notice that's not on here is opioids. The American Academy of Orthopedic Surgeons and the American Association of Orthopedic Surgeons have strong statements completely against the use of opioids for chronic pain, including arthritic pain. It does not make the problem better. It makes the problem worse and harder to deal with down the road. Injections. Steroid injections are an anti-inflammatory injection. We try not to do those more than about 3 or 4 times per year. The reason there is that the steroid can have a diminutive effect on the cartilage itself. So if we're trying to treat a wearing out joint, you may be making the problem a little bit worse if you're doing it all the time. That being said, it's a very good way to treat patients. It has less systemic effects than other anti-inflammatories, so some patients, that's a great option for them and gets them by, particularly in patients who are poor surgical candidates. Lubricating injections, so things called viscosupplementation injections, Synvisc, Hyligan, all those things that are basically hyaluronic acid. It's a high molecular weight version of the fluid that's in your joint. The idea was this is going to lubricate the joint. You'll hear patients talk about that a lot. We're seeing insurance companies pay for this less and less because they're following the data here. They found out these injections are $1,500 or so for a series of injections typically. And large randomized studies comparing viscosupplementation versus saline showed no superiority of the viscosupplementation over saline. So now the AAOS, again, is not recommending their use for the treatment of arthritis, and I think we'll see this continue to fade away as we get further along. I will briefly mention the stem cell and PRP because Dr. Dawson's going to talk about this a lot. I think this is a very good option. It's becoming more and more available. The cost has gone down substantially. The out-of-pocket expense for PRP, for example, should be somewhere in the $300 to $500 range. I think that as we get more and more data that they are somewhat effective for moderate arthritis, that we'll see more insurance payers eventually pick this up because that's a heck of a lot cheaper than joint replacement, and if you can get by with that, they would see the cost benefit there. Supplements, lots of folks taking glucosamine and chondroitin, not FDA regulated, very few side effects, probably not all that effective, but I don't have a problem with it if they want to try it. It may be anti-inflammatory. You got folks that will swear by it, and I don't think there's a lot of harm if they want to try it. I didn't mention one other treatment here that I'm seeing a lot more of is CBD treatment. The anecdotal data, everyone is talking about this, says it works great. I have not yet seen a study of it on arthritic pain yet, but I'm looking for that to come soon and see where that goes. But everyone here has someone that said they've been using CBD oil and made their pain go away instantly, I'm sure. So who needs a surgery? What's surgery good for? Who's it good for? We look for good joint replacement candidates who have failed conservative measures, that they're medically optimized and they understand what they're getting into and that they understand what risks they're taking. It's about over 1 million patients annually. The goals of surgery are to get rid of the pain and improve their mobility and return them to the active lifestyle that they wish to go back to. What has changed in joint replacement? This is primarily with hip and knee replacement was what I'm going to focus on. And over the past 3 decades, you'll see, or 4 decades almost now, you'll see how much things have changed. In the 70s and 80s, joint replacement was this kind of experimental procedure with very unpredictable results. We would oftentimes cast patients after surgery. We didn't really want them to move. There were all these wards where patients would be non-weight bearing and they'd be in traction or in cast in a bed for 3 or 4 months at a time at times, and they stayed in the hospital for 2 to 3 weeks. As you can imagine, blood clots, things like that were very common. Pneumonia was very common. It was a limb salvage type of operation. The 1990s, we said, okay, well, maybe we can get these patients moving better if we just control their pain. So we really focused hard on pain control. We used narcotics a lot, and that was the problem in that regard. We had people using PCAs where they were giving themselves narcotics with a push of a button in the hospital. They'd stay for 5 to 7 days. Complications were more common because they're staying in the hospital, they're staying in bed, they're not moving. So DVT and PE was something that was occurring very, very frequently. The 2000s, we thought, okay, well, maybe our surgery is too big, so we're going to make these really small incisions, and the minimally invasive operations exploded. And that had some benefit, and our instrumentation got a lot better, but our outcomes didn't follow that. We found we were talking about 2 incision hip replacements or mini knees, and the whole goal was to try to do the joint replacement as small of an incision as possible. The unfortunate part about that is the incision on the skin doesn't necessarily represent the trauma to the body, and really what matters is taking care of the musculature and the ligaments underneath and doing a safe surgery. We had a lot more complications from surgery because we couldn't see what we were doing, and if you don't put the parts in right, it probably doesn't work very well. And that gets us to where we are today, which is really kind of rapid recovery joint replacement. We realize that you can't focus on just one piece of the puzzle. You have to look at the whole picture, from anesthesia to pre-op to education to post-op to doing a good surgery. And this is kind of the way that I look at joint replacement now. I look at it with this 6 kind of fields in which we care about things, from education, before and after surgery, mobility, pain control, pre-op planning, both surgically and interdisciplinary, efficient surgery, and then risk stratification. So mobility, many of the side effects from a joint replacement surgery were things that we told them they couldn't do. We used to tell patients you can't weight bear after surgery. You used to tell patients you can't bend your hip over 90, you can't turn your leg this way, you can't do that, you can't sleep here however you want. It made surgery really, really hard to recover from. So this becomes a delicate balance for the surgeon, where if you hold the patient still for 6 weeks, and probably not going to have a problem with your operation, but then you have the risk of all the immobility that's occurring, such as pneumonia, wound healing, things of that sort. So having approaches to the joints and having ways that we can allow them to mobilize safely is really important. That's where we work very, very closely with our physical therapists. We do physical therapy on the day of surgery. Within hours of their operation, they're up walking. Most patients, if they're able to, or weight bearing is tolerated, and we discuss all this before surgery and we discuss it after surgery so that they know what they're going to be doing. When I sit in clinic with someone and tell them they're getting their joint replaced, I say, you're going to be walking an hour or 2 after the operation. And they're expecting it and they're going. And then we know what kind of crutches and walkers and stuff like that they need ahead of time, and we get those things ordered and paid for and taken care of. Education, as we talked about, Devin runs an awesome joint class here at the hospital, and she goes over all these expectations with the patients. The physical therapists come down and meet with them. The pharmacist meets with them. They see their hospitalist at that time. They get all this material over and over, and it's the same message every single time. We also include it on our webpage, so it makes it easy for them to get to when they're at home and when they're looking for who they want to do their joint replacement. Risk stratification, everyone gets a comprehensive medical evaluation. Clearance is a relative term. No one's technically ever cleared from surgery. You're optimized for surgery to make sure that you're in the best tip-top shape you can be to undergo the operation safely. We look at a preoperative risk calculation. Here's a few things that we look at for the primary care folks that are in the audience. Cardiac evaluation for those who need it. Those who've had a history of coronary disease are oftentimes being seen by a cardiologist. A1C of less than 8% is a hard cutoff for us for elective surgery. Fructosamine is a lab that we use too. So let's say you got that patient who's 8.1 and their labs 6 months ago they were 7.5, and they promise you they've been doing so much better and they want to get right on the schedule. Fructosamine is a 2-week average of your blood sugar. So 292 equates to about a hemoglobin A1C of 7.5. So if they're under 292, that tells me they've done a better job recently. And then looking at preoperative anemia, we don't really want to operate on people that start out less than 11. And then electrolytes. Preoperative planning, as I mentioned, that's both surgical and interdisciplinary. You're going to know what you're going to plan to do and recreate your plan. So from a surgical standpoint, looking at every case and know what I'm going to do. And then we have an interdisciplinary meeting where I talk with therapy and care management and the vendor for the implants and DME. Everyone knows what the plan is for that patient, so they hit the door, and it's a smooth process that goes from admission to discharge. Efficient surgery, I don't like to say fast surgery because that sounds bad, but what efficient surgery means is decreased muscle damage. Small incision does not mean small trauma. Have less blood loss and have less stretching of the tissues and nerves. So do the operation once and do it right the first time so that the patient can recover very quickly. This is something you probably hear a lot about. People ask you questions, should I go down to X hospital and get a robotic joint replacement? We've looked at this a lot. I look at it really closely. I work with a couple of the implant companies that make these and try to get us to buy the $1.6 million robot that they make. So we've looked at this outcome-wise, and I kind of use this analogy with robotics right now, that we think of robotics as kind of like bumper bowling. It does a great job for keeping you in your lanes, keeps you from having these really big outliers. It's a really good operation, really good choice for low volume surgeons who need the bumpers. So when you take your kid bowling, they probably need the bumpers. When you watch bowling on ESPN3, they don't need the bumpers. So when the 10-year follow-up, what I'm looking for, what I'm waiting for with robotics is for us to get a study that shows it, that makes me do a better job. The most recent study we have of this, 10-year data, shows that when you have a robotic knee replacement compared to a traditional instrumentation with a high volume surgeon, that the overall survivorship, complications, and most importantly, outcome scores for patients are all the same. So until we can prove that we're doing a better job with it, it's just a tool for advertising, honestly. I mean, that's what the places that have high competition are looking for, ways to delineate themselves from other practices. We've mentioned this, pain control. Avoiding narcotics and using multimodal pain control. Our anesthesiologists do a great job of regional and spinal anesthesia. COX-2 inhibitors work great and are safe around surgery to reduce your need of narcotics. And then I use steroids fairly liberally in the first 24 hours to help reduce inflammation and nausea. This is a video of a patient who is about 2 hours after hip replacement walking in our recovery room. He's going to be going home in about 30 minutes from there. So joint replacement is one of these things where you can get up and move very quickly, and there's really no reason to be stuck in a hospital if you're a healthy individual. This is the morning after knee replacement, range of motion after. This isn't a small guy by any means. You can see range of motion and quadriceps function. For our therapists, are probably seeing that and realizing you got good quad tone right after surgery. That's really important. It helps them safely mobilize and makes their fall risk really low. This is how fast this lady came to me in need of a bilateral hip replacement. She had terrible hip arthritis, and you can kind of see by the way her back is, she has a hard time walking. She was hunched over using a walker at that time when I first met her, and this is at her first post-op appointment after a bilateral hip replacement, walking with a fairly normal gait just 4 weeks after having both of her hips replaced at the same setting. So moving pretty good. This is what I'm most excited about, most proud of that we're doing here. The collaboration between my practice and Mosaic Life Care has been amazing. We are striving for Joint Commission Center of Excellence status. This is a program where JACO comes in and evaluates our joint replacement program and has looks at the standardization, looks at how good we're doing across the entire continuum of care, and the emphasis is on outcomes. We want to use this program as an opportunity for us to continue to improve our outcomes in joint replacement, and we're hopeful that sometime in the next 6 months or so we'll be applying for and hopefully receiving Center of Excellence status from the Joint Commission. That's all I have for joint replacement. If there's ever any questions about hip and knee replacement, that's kind of all I do, with the exception of just being stuff on call. So feel free to reach out to me anytime, especially any of our patients or anything that I can ever answer questions or help take care of your folks better. We're always here for that. What questions do you have? Yeah.
Can you just tell me just a little bit, a lot of people don't know about your walking clinic, what services you actually offer?
Yeah. Actually, so we have the OSMC today is basically like an ortho urgent care. It's for the patients who have sprains or even fractures come through. The convenient thing about it is that we have a PA who runs that clinic 7:30 to 4:30 every day, and we have on-site imaging, we have on-site MRI available, and then there's also on-site surgeons available. So it's not uncommon to see the PA and come up and say, hey, we gotta get this fixed and fix that fracture this afternoon. I mean, it's a convenient thing. No appointment needed. Just show up and get you seen and take care of it. Goal there is to kind of keep people out of the ER. That, you know, ERs get backed up with sick people that need to be there, and oftentimes orthopedic issues are not emergencies, are more urgencies. Yeah.
How do you counsel younger patients with osteoarthritis who are looking at joint replacement or wanting joint replacement?
Younger patients, it really depends on what joint we're talking about. From a knee replacement standpoint, our data on patients that are over 50 is getting better and better. Under 50, I try to find ways to get them a little bit further along. We talk about what the risk factors are for it, what activities they're trying to do. Are there other alternatives that can be done? Whether or not we're going to send them to Dr. Smith for a high tibial osteotomy, things like that could potentially be done in really young patients. Hip replacements, it comes down to when your quality of life affects your activities. I don't see an age limit on hip replacements. I've done them on teenagers if needed. There's been a couple 18 or 17-year-olds that have had post-traumatic arthritis or Perthes or a skiffy that's failed. Our data on hip replacement and shows that they can get back to any and all activities they want to do. I mean, professional athletes have joint replacements now and can get back to their life. All right, any other questions? Very good. All right, thank you very much.
So I'm Pete Dawson. PRP is my talk, basically, but we're going to talk about a lot more than that. I did my residency, like Dr. Peterson said, at Mizzou, and then went and did a sports medicine fellowship at UC Davis in California in Sacramento. And most of this stuff I would say I got from fellowship, not really from residency. I want to preface my talk with there's really not great evidence for any of this stuff. So we'll talk about that a little bit. There are a few things that regenerative medicine has been shown to be really helpful for. A lot of it is anecdotal or really low quality studies or small number studies. So it's kind of a risk benefit thing whenever we go into all this stuff. Okay. Oh yeah, and thank you for letting me talk with you guys. And Kate's not here. For giving me a reason to wear my jacket, which I don't get to do very often. All right, so I don't have any conflicts, I don't think. And the other thing, pretty much everything is off-label or experimental, according to, sort of like, it's one of the more irritating terms that I think we have to deal with is when things are considered experimental. It's not really experimental, there's just not enough evidence sometimes for things. But neither here nor there. First, these are kind of our bullet points of the talk. First thing we're going to talk about is what is it? And then we'll talk a little bit about the rehab after it, so you just kind of have an idea. I want you guys to be able to kind of know what regenerative medicine is, and then be able to if patients ask you questions, have a somewhat informed discussion with them. That's really the goal. There's too much to get into with a 20-minute talk, and hopefully less than 20. Okay, what is it? So if you Google regenerative medicine, you get all of these things like generation and use of therapeutic stem cells, tissue engineering, the production of artificial organs. We're not doing any of that here. Restoring organ tissue and organ function. This would be considered regenerative. This is a study that's going on at Mayo, where they're actually infecting cartilage with virus genomes and trying to restore cartilage or actually grow cartilage in the knee. So that's early on in their study period, but they are doing it with humans now. But this is kind of more what we're talking about here. Stem cells, platelet-rich plasma, also something called prolotherapy, which is, and we're not regrowing limbs either, like the salamander. Pretty impressive. I think we could learn a lot from the salamander. So injury and healing response. So in order to really understand what this regenerative medicine thing is all about, you kind of have to understand what happens when you get hurt. So you get injured, and initially after injury you have this acute inflammatory phase, and you've all seen that. Somebody sprains their ankle, it gets big and swollen and puffy and very painful. You have bleeding into the area, you have platelets that get into the area from the blood, as well as all these neutrophils, monocytes, all of these growth factors and inflammatory factors. And ultimately the goal is to remove all the dead, damaged tissue. So that's acute inflammatory phase. Second phase is the proliferative or regenerative or repair phase. So this phase starts, maybe a few days after these growth factors have all gotten into the area, drawn in the fibroblast cells. They lay down new collagen and this disorganized scar tissue. So if you look at like an MCL tear, it's going to have this scar tissue in there, but it's not going to look like a normal MCL during this proliferative phase. And then you have the tissue remodeling phase, which is similar to like turnover in bone. In bone you have osteoblasts and osteoclasts, and they're constantly like kind of working against each other to reorganize bone. So the same thing will happen with collagen and the matrix that it lives in to organize this tissue to get back to what it's supposed to look like. So ideally you go through all these phases and then you have a healed tissue and it looks better and it feels better and it works like it's supposed to. That doesn't always happen. Sometimes you can plateau, and this process here could take 1.5 years of continual tissue remodeling, which is a long time, and it may get to the point where it just sort of stalls out. And the idea behind these regenerative-based treatments is that we essentially move back up to phase 1 and start over. So when people get these kind of treatments, these injections, they tend to hurt. It's just like having, if I did an injection of PRP into their ankle, it would feel like they sprained their ankle, and that's normal. So we start the process over and try to basically get it to go back down here in this remodeling phase again. Regenerative medicine is an interventional non-surgical attempt to restore a tissue to normal or near normal health and function. It relies heavily on your own body. Like, your body has the capacity to heal. And this is why I think some people probably respond better than others. Some people have more capacity to heal than others. But this treatment augments the patient's capacity to heal. So it takes what they have, makes it better. And what we get is the big question that studies are not really able to help us with right now. Rehabilitation is an important component of treatment. If I do some kind of regenerative-based treatment on, say a shoulder, rotator cuff tear, something like that, if they don't do therapy for it, it's not really gonna have a great response. The therapy is super important, and I think probably the surgeons would say the same thing about their surgeries. They're not as good if you don't do the therapy with them. So I kind of describe this to patients as putting gas in the car. So without the gas, the healing process or the car is not going to drive. So we basically irritate this tissue and put gas in it so that it will start healing. And that's the analogy I use pretty typically, and people seem to get it. So there are all these different types of regenerating or trying to heal tissue. This first one is really the only one that is like regularly covered by insurance because it's billed as an injection into a tendon. But it's called a tenotomy or a tendon fenestration. It's not actually a tenotomy. I call it a tendon fenestration to be more accurate. But all we're doing is, for this, numbing the tendon and then needling it. So it would be similar to dry needling, except because I numb it, I can use a way bigger needle than like what Chris can use in our therapy clinic. So what we've got here is gluteal tendon here. So we've got anterior facet, which is the gluteus minimus, and with tendinopathies or like wear and tear kind of injuries to the tendon, they tend to get really thick and swollen and dark on ultrasound, so it makes for a really easy target. And what you see here is basically this kind of turned sideways. So you've got needle going into the tendon, and this needle is going to go in, pull it out, redirect, in here, pull it out, redirect. And then we're going to move the ultrasound over and we're going to do the same thing. And we're spraining the tendon intentionally. So it's an iatrogenic injury. PRP is something that we can offer here. I would say that I probably do a handful of PRP injections each week. I find that it's the most useful in soft tissue injuries, so mostly tendons or ligaments. We do it into joints and have had some people that have done really well with joint injections, and we'll talk a little bit more about that. But basically all we're going to do, draw blood, put it in the centrifuge. It spins around like 10,000 times a minute or a second or something like that, a lot, really fast. And then we take this platelet-rich layer of our after it spins in the centrifuge, and we literally inject it right into the tendon. So with that fenestration that we had just talked about, as I'm doing the needling, I would also just be injecting this stuff. Or if they have like a focal tear, I'm going to put a whole lot of it into the tear specifically. Stem cells. So this is a picture of how you get bone marrow stem cells. It's the same way you would for like a cancer if you needed a bone marrow biopsy, you use a ginormous needle and jam it into the iliac crest. It's very painful. Usually after this procedure, their hip hurts more than anything else from getting that giant needle shoved in there. You can get it from peripheral blood, and there's a kit that we can get that does that. It's going to be slightly different stem cells, and you can get it from adipose, and a lot of people are using stem cells out of adipose tissue, so you almost get like a mini liposuction when you do it. They put this plastic needle into the stomach and they move it around and suck until they get a whole bunch of fat out, and then they will spin that. So it's kind of gruesome to watch, but we don't know. Like with stem cells, they cost a lot more than PRP to do, and there's not really any study that says that they're any better. So usually I will kind of counsel people that if they're really pushing their budget, it's not worth it to spend the extra $1,000 to do stem cells. Maybe at some point it will be, but right now it's just not there. And it costs these people. I've seen people that have spent $5,000 to $10,000 on stem cell treatments, and they're no better than they were before they ever got it. So it's really hard for me to see people that are just, they'll eat up the marketing for this stuff. So prolotherapy, technically speaking, all of these are forms of prolotherapy, but typically when you hear the term prolotherapy, it refers to injecting sugar, like various concentrations, D5 to D50, a bunch of dextrose into tissue, essentially doing the same thing as what we've already talked about with the other stuff. You can buy ozone and inject ozone. I don't know what ozone looks like, if it's a liquid, or I've never seen it before, but it's in a dark bottle so you can't see what's in there. And there are some other things that people will inject for prolotherapy, but prolo stands for proliferative, and these are all forms of proliferative therapies. There's your dark bottle. I've seen that before. Okay, so the important part of this, the rehab, this is like the chart. So if you ever see a rehab protocol after a PRP or a stem cell treatment, it's almost certainly based on this. If you Google rehab after PRP, it may not look like this, but every bullet point is like identical. So this is the one to know. I'm not going to go over all of this in detail. That's ridiculous, but I'm happy to share it with you guys if you want. I think it came out of the PM&R journal actually, and I can send it to you or share a reference or something like that if you'd like it. But whenever we do these treatments, we try to send this or a similar like broken down copy of this to the therapist so that you guys will have it. Rehab after regenerative treatments. Rehab phases are based on pathology. So this goes back to that phase, the inflammation, proliferation, remodeling, and also on what tissue. So if we're doing something like an intratendinous injection into an Achilles, I'm probably going to be a little more conservative with how fast I get them loading that tendon. Just because of the worst case scenario of rupture, and then Dr. Miller's got to operate on them. Okay, so phases of rehab. The first week, tissue protection. Any lower extremity, I'm typically going to put them into a boot or crutches or something to just protect it for a week. After a week, you can generally come out of it, and you're not stretching. The main thing is do your normal day-to-day stuff, but don't push your range of motion too much because you're laying down all of that collagen and you're starting to proliferate here. So in the third week, you can start adding some light resistance, more high rep stuff, and not doing a bunch of eccentric. And then after that, it kind of goes more towards your like standard rehab of any injury, with less worrying about protection and more about development. Overall, the rehab is variable, and it depends a little on the person and how they're doing, but generally, like this chart will take you about 3 months. Some people do really well a lot faster than that. I generally will tell people that the healing process after one of these types of shots is about 3 months. So once you get to 3 months, that's kind of where you are. And if you got a lot of improvement, but you're not quite there yet, we can talk about, is it worth repeating something? If you didn't get any benefit from it, we're certainly not going to do it again. There's no point. So who should get it? Risk benefit, really. You can use it for acute issues or chronic issues. To me, there is some evidence for acute injuries, particularly the ulnar collateral ligament of the elbow and this high ankle sprain. They've shown faster return to play after getting it for a high ankle sprain. On the other hand, most of the people getting high ankle sprains are high school kids, and they don't have $300 to $500 to spend on an injection to get them back 2 or 3 weeks sooner. So we have to take all that into consideration. If they're a professional athlete, they're getting it. And the professional athlete will be back sooner. Steph Curry got it during the playoffs, I think, last year or the year before. Basic science-wise, it doesn't make sense why it would get you back faster because you've already got that process happening, but they've shown it, I guess. Chronic issues are where I think this stuff really has a role. Oftentimes with these chronic issues, there may not be a surgical solution. Somebody who's got this chronic rotator cuff tendinopathy and they have rotator cuff pain, but there's nothing like that you can surgically repair. Those people do really well with these treatments. Obviously, if they have a big tear or they have something surgical, I'm going to send them to see the surgeons and get it fixed. But once they've reached the chronic stage, a lot of them they got to the chronic stage because there wasn't something surgical. And that's where reinitiating the inflammatory cascade really makes sense, and physiologically or biologically, following that, go back to stage 1 and start over, collect $200. The other thing that it's frequently used for, and there actually is evidence for, is this intra-articular injections into the knee specifically. This is, I think, the only like quality study for it. But even with a quality study, like they got great results, but they had people come back and do it 3 times. So every other week they did an injection into the knee of this PRP, and every one of them cost them probably $500. And so they spent $1,500 on this series of knee injections for their arthritis. We don't know if they need to get 3. They might only need 1. We only do it once when we do it for knee arthritis. And I would say that the people that do better don't really need another one. And again, like this is where the evidence lacks. So I have to have this conversation with everybody. Like, is it worth it? Do you have the financial resources to want to pursue this? Or would you be better off just getting your knee replaced? Or doing repeated steroid injections, which I have, my own reservations about. Okay, so is this person a good candidate for PRP?
Yes.
maybe in that hip. So really bad hip there. I just had to put that on. Okay, so here's my approach. This is how I handle like when I see these patients in clinic. It often takes longer to see them because we have a long conversation about how there's really not great evidence. This is what I think is going to happen. This is your part that you have to play. The rehab is important. So we go through all of this stuff, and it takes time. And so this is where I'm happy to see these people and discuss it with them, but I want you guys to kind of have an idea so that when you see them, you can kind of tell them what to expect. Occasionally, they do need an MRI. If I see someone and they've got a lot of weakness in their shoulder as well as pain, and I'm concerned about a big rotator cuff tear, I'm not going to inject anything until I get an MRI. Sometimes it's pretty clear what they have. If they've got jumper's knee and they've got a big dark spot when I stick the ultrasound probe on them and that's where it hurts them, then we don't necessarily need to get an MRI for that. We can just inject it. That's if they need it. I'm going to send them to therapy first. And a lot of these people do so much better once they commit to doing therapy that I find they don't end up needing these kind of treatments, which takes away some of my fun, I guess. Other things to consider: what is their work? What time of year? Are they a heating and air conditioning guy and it's 95 degrees all the time? They can't do this stuff right now where they're going to have to be like lifting air conditioner units and doing all kinds of overhead work. Are they in season or out of season in sports? What's the likelihood of making them worse? I don't like to make people worse. I definitely try not to do that. Are they a good surgical candidate, or is there no way anybody's going to operate on them? Because that also makes a difference. If they can't have a surgery, then maybe this is their best option, and it's at least worth discussing with them. How acute is their pain? This is a really important one because I don't really like using a lot of steroid. I would say I probably use a lot of steroid, but I don't really like it because of the side effects it has on tissues as well as the rest of the body. But if they're in a ton of acute pain, I'm not going to do a regenerative procedure on them because it's just going to make them hurt more, and it's going to take several months before they start to feel better. So in that case, we talk about, do we want to try doing like a steroid injection, get you feeling better, and then if it starts to flare back up, deal with it sooner rather than letting it get as bad as it did. Okay, what do I need to know? So here's your take-home points. These are targeted injections with the potential to heal damaged tissue. I think the targeting is important with this. Like if you have pain in your leg and you get a steroid shot in your butt, your leg's probably going to feel better. But if you have pain in your leg and you get a shot in your butt with PRP, your leg's not going to feel any better. Like it's very important that we actually hit the pathologic tissue. So for extra articular or things that need guidance, we have that in the clinic with our ultrasound that Dr. Gertken kind of talked about. These are providing the gas, but you need your body and your rehab to be able to drive the healing process. That we sort of plateau around 3 months. Initially, there's that. Oftentimes, it hurts more, and I will actually give people pain. This is one of the few times that I give people pain medications after doing this because I don't want them to take anti-inflammatories, which may be my next. Nope. I don't want them to take anti-inflammatories after doing this. So I will give them pain medicines for a few days, and usually by that time, they're just back to baseline. More likely to benefit for soft tissues. Cost is really the major risk for this because it's typically not covered. We have found that occasionally we'll get it covered for tennis elbow or for knee arthritis sometimes. It's really variable from insurance to insurance. So we always attempt to prior auth and rarely get it approved, but sometimes it does get covered for people. And there are multiple regenerative means of accomplishing the same goal. And we can inject whole blood here. We can inject PRP here. I've not done any like sugar-based prolotherapy here. We did some in fellowship. We've talked about getting stem cells, but just have not found that having the equipment will likely not justify the cost of the procedure and getting it. I think it will cost us a lot of money if we were to try and do that. Cute kitty. Here's my girls, because most talks always seem to end with the obligatory picture of your family, so I threw that on there.